there. So I've started the YouTube live, and now we can start the program proper. I welcome all the dignitaries to this Searchlight 30 on updates on antenatal monitoring. Before we take the program forward, we take the blessings of the divine. So we just join hands and take the blessings of the divine before we start the program proper.
वक्रतुंड महाकाय सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देवा सर्वकार्येषु सर्वदा.
With pranams to the divine, I would like to introduce my convener for this program, Dr. Sujayasri Sangita. She is the secretary of Bhimavaram Obstetric Gynec Society. She runs 2 hospitals at Palakol and Malikapuram. She is the founder secretary of Bhimavaram Gynec Society and also the secretary of IMA Palakol. She has Shanas Ratnam Young Gynec Award, Foxy Dhira Award. She is interested in laparoscopy and infertility, has paper presentations at multiple conferences, and does a lot of community work, and has also received award of recognition by the District Lions Club. Over to you, Sujayasri. Welcome,
thank you, ma'am.
Welcome to this program.
Thank you, ma'am, for that kind introduction. Moving forward, I would like to introduce the program director, Dr. Asha Jain, ma'am, who honestly needs no introduction. But currently, she is the director of SMSA Hospital Raipur. She is the medical director of CPRS. She's the elected member of CG Medical Council, Zonal Chair, Foxy, Food, Drug and Medico-Surgical Equipment Committee, West Zone. She's the chairman of Mission Pink Health, IMA Raipur, and also the executive member of ISCCP, Chhattisgarh, ISAR, and SFM chapter. Madam, the previous post held by ma'am, she has been the president of Raipur OB-GYN Society and also the vice president of IMA Chhattisgarh and the president of Rotary Club of Raipur North. She has received training in colposcopy. She's a certified trainer for the same. Madam is standing currently for the post of chairperson for the Committee of Food, Drug, Medico-Surgical Equipment. So requesting everyone to please support ma'am. And I request ma'am to please introduce the chief guest and onward.
Thank you, Sujayasri. Thank you for the kind introduction. And I would like to welcome our chief guest, Dr. Kamal Buckshee, ma'am, our guest of honor, Dr. Archana Verma, ma'am, and our speakers, Dr. Meena Samant and Dr. Sujit Kondkar, chairpersons, Dr. Parneet Kaur, ma'am, Dr. Pradnya Harshy, Dr. Neeta Ghate, Dr. Geeta A, Dr. Datta Panandikar, and Dr. Sridevi, ma'am. I would also like to welcome our expert, Dr. Uma Shankar sir, and our panelists, Dr. Kiran Sonvalkar, Dr. Amrita Kumthekar, Dr. Samia Mufti, Dr. Ujjwala Bardapurkar, Dr. Uma Brinda, Dr. Monica Umbardan, Dr. Jigyasa Dengra, Dr. Prerna Kishan, and Dr. Sujata Velanki. I also welcome Dr. Sujayasri. I'm really grateful that all of you have shared your time and your knowledge so that we can all meet together in this evening. Now, I would like to introduce our Chief guest, welcome, ma'am. We are really honored to have a living legend like you with us this evening.
But
Ma'am
that's
was a former professor and HOD Gynae at AIMS Delhi. She is Emeritus Professor, National Academy of Medical Sciences of India, first President of FOXY from Delhi in 1995, first President of ISOPAP Delhi 94 to 96, has the BC Roy National Award, Eminent Medical Teacher. She is the recipient of Senior Scientism Award WHO 1972 for Feto-Maternal Unit Study, Stockholm, Sweden, Indo-Norwegian IVF RT, Oslo, Norway and Commonwealth. First time in India, she is an obstetrician who performed fetal blood sampling. So now that we are doing, this program is so much on fetal medicine. So, ma'am, we are really honored to have you. And there are so many accolades that she has. So, welcome, ma'am. We would really love to have few words of blessings and guidance from you.
dear Asha, Dr. Asha Jain, and all the dignitaries. What a great scientist you are. And when I see the sea behind, and with the lovely palm tree breezing away, each one of you has so much of knowledge that I'm humbled and honored to have people like you who have invited me. I am going to learn from you. Now, the updates on antenatal is one of the most crucial topics. And before even when a patient comes, it is very important that we must take the pedigree, at least 3 generations, because that is very important. Second, now the mother, dear Archana, good morning and pranam to you. Lovely. And the patient who's, whether is she anemic, is she thalassemic, is she sickle cell disease, is she diabetic? So we must know that this young lady who's going to have a baby, that she must be in the best of her health, because as far as the fetus is concerned, to have the brilliant fetuses or the brilliant scientists who are all here, when I look at Sujit and everybody, and I'm sure those obstetricians must have looked after your moms very nicely, that we have such talented people. Now, when we come to pregnancy, it is the earliest period when a patient doesn't even know what food she should eat, no drugs, and nowadays the younger generation, whether it is alcohol, whether it is anything, so we have to be very careful. Then when we come to the antenatal monitoring, the ultrasound, you have to have the third eye of the Lord Shiva to know as far as there is any anomaly as far as the fetus is concerned. And if suppose there are multiple pregnancy, one fetus may be normal and the other fetus may be abnormal. So I will stop short because we have such great speakers, and I wouldn't like to, and I would bless you all. And today I'm going to be one of the students. I'm tempted to listen to all of you because science is growing so much in leaps and bounds. It was just the in utero transfusion. Now we are doing laser, fetal, so much of work as far as the abnormal babies are concerned. Then microarray, there is a vast ocean as far as the knowledge is concerned. Thank you, Asha ji, and each one of you for inviting me to be updated to know what is latest. Pranam.
Pranam, ma'am. Pranam for being with us. And your words of guidance will be guiding us all the time. And I hope you keep good health and keep joining us, till you're able to, because a lot of students, and all of us are students at some stage, we really do need guidance. And now we have dear Archana Verma ma'am with us. She is like a mentor to me in Foxy, and she will always say, okay, Asha. If I'm in trouble, if I call her, she'll say, okay, Asha. So, ma'am, it is my honor and pleasure to introduce you. Ma'am was the past VP Foxy. She was also the past PSC committee chair, to which she took to great heights. We had that All India walk and whatnot. She is the founder president of West UP ISOPAP chapter, advisor of UP COG, organizing chairperson UP COG 2020, past president Ghaziabad Society, organized so many conferences, is an executive member for NNF India, executive member Endocrinology Committee SAFOG, executive member EOFOG Onco Committee, and has a whole list of awards. So, ma'am, requesting you to please bless us.
Okay. Thank you, Asha. Thank you so much. First of all, my namaskar and pranam to our motherly figure, Dr. Professor Kamal Buckshee, madam. If she is there at any platform, anywhere, you know, we are all are blessed. And this is 100%, rather 200% the truth. And whatever she said, still, I mean, the look at her humbleness. She says, I'm learning, I will learn a lot from you. And you know, she is that full of knowledge, full of love. We all look for and we always vouch for. And very true, Asha ji, your excellent academic program will help a lot. And it is going to be a really a perfect searchlight program you have made, because since ages everybody is searching for knowledge and wisdom, and if these two are together, we can do a lot together. And you have a fantastic program and fantastic speakers, and I wish you best in the future also. And great program, antenatal screening, of course, because women are the main pillars of society, and they are the producers of future generations. And if we are taking care of women and the fetus, indeed we are doing a lot of justice and as a good work, and without any much ego also, because so many, everybody contributes to society at any level. So one should not think that only big people can do a bigger काम, and हम लोग सब लोग मिलके ही कुछ काम कर पाते हैं. मैं तो बहुत छोटी हूँ इस गैलेक्सी में, and I would always like to be with you all people. Thank you very much. Thank you so much. I'm not taking name
Thank
of
you,
all
ma'am.
आशा जी, because आपने सबको बहुत अच्छे से नाम लिया है, और I can see everybody. मैं थोड़ा लिखूंगी भी, because you know, it is time is short. Thank you very much.
Thank you, ma'am. मुझे बताइए, मुझसे कोई गलती हो गई है क्या?
आशा कहाँ हुई?
मतलब मैं आशा जी कैसे हो गई, इसलिए पूछ रही हूँ.
तारीफ करूं और कितनी तारीफ करूं, यू नो, ऐसे एकेडमिक प्रोग्राम में आशा जी लगाना ठीक है.
आपके लिए तो आशा ही हूँ, है ना?
आशा, यस आशा.
चलिए, नमस्ते.
होप फॉर ऑल.
नमस्ते. थैंक यू.
अब चाहते हैं कि आशा जी को हर इंसान हर कोने से वोट दे, ताकि because she is standing for an excellent committee, and I would say all of you who are taking part to stand, we must all vote fully so that they all do the best, because they have great capacities.
Yes, really, very
Thank you,
true,
ma'am.
madam.
Thank you so much.
And Sujit is also there. All good wishes.
Yes, we must have him, vote for him also.
So, Sujaya,
Yes,
would you
ma'am.
introduce the chairpersons,
Yeah.
please?
So, yeah, firstly, I would like to thank all the chief guests and the guests of honor for the supportive words. So, moving ahead to our first session, which is antenatal monitoring, why, when, and how. The speaker for the same is Dr. Meena Samant, ma'am, and I would like to introduce the chairpersons for this session. Firstly, we have Dr. Parneet Kaur. Madam is the professor and head of Department of OB-GYN in GMC Patiala. She has a teaching experience of 23 years. She's been an examiner for undergraduate and postgraduate students. She has multiple publications to her credit. She's contributed chapters in books and reviewed journals. She's currently the president of Nabha OB-GYN Society. It's a great honor to have you with us today here, ma'am. Welcome to today's session. The next chairperson is Dr. Pradnya Harshy. Madam is the director of Harshy Hospital, Jabalpur. She's a consultant at the same. She is the executive member of the Jabalpur Menopause Society, currently the president of the same, and she has previously been the vice president of the same society. And it's a great honor to have you with us, ma'am. Welcome. We have Dr. Neeta Sunil Ghate, ma'am, with us. She's a practicing gynecologist for the last 29 years. She has been practicing in Markande Ranganaya since 26 years. She's the president of Solapur OB-GYN Society. She's an honorary teacher and she has done her fellowship in minimal access surgery. Ma'am, welcome to today's session. I request one of the speakers, Dr. Parneet Kaur, ma'am, would you like to introduce the speaker for this session, ma'am? Dr. Meena Samant.
Good evening, everyone. I'm Dr. Parneet Kaur. I'm thankful to Dr. Asha for inviting us for this very important webinar. The first speaker is Dr. Meena Samant. She is senior consultant and HOD at Kurli Holy Family Hospital, Patna. She is president of Patna Ops and Gynae Society. She is vice president last year of ISOPAP. She is chairperson of Foxy Clinical Research Committee from the year 2019 to 22. She has in her kitty Kamni Rao Ration Award in 2005. She was organizing secretary for Yuva Foxy 2011, organizing secretary for BoxCon 2018. She is a DNB teacher and has published many papers in reputed journals and chapters in books. Ma'am will be speaking on antenatal monitoring. A crisp introduction has already been given by Dr. Kamal Buckshee. So it is over to Dr. Meena for her topic on antenatal monitoring. Over to Dr. Meena.
Thank you, Dr. Kaur, for that kind introduction. Chairperson, Madam Kaur, Madam Harshy, Dr. Neeta Ghate, and respected chief guest for today's program, Dr. Kamal Buckshee, Madam, and the person behind today's show and all the Searchlight series that's been going on, Dr. Asha Jain, ma'am, all the dignitaries, a very good evening to all of you. And I thank Dr. Asha for giving me this opportunity to speak here in front of you. My topic is a little broad-based. I have concised it so that I can touch upon everything. Are my slides visible?
Yeah.
Yes, ma'am, you need to make it full screen.
Yes,
Yeah.
ma'am.
Okay. So antenatal monitoring, what, why, when, and how. This is what I'm going to touch on. And before I go into that, a few words by J.W. Williams. The borderline between health and disease is less distinctly marked during gestation. Just a second. And it becomes necessary to keep pregnant patients under strict supervision and to be constantly on alert for the appearance of untoward symptoms. Way back in 1903, and I thought, because Williams obstetrics still continues to be a kind of Bible to many of us like me, so I thought I will start with his words. I think these words still hold true more than a century now. And the primary aim of antenatal care is to promote and protect the health of women and their unborn babies during pregnancy so as to achieve at the end of a pregnancy a healthy mother and a healthy baby, to reduce the mortality and morbidity of these women and children, and to improve the physical, mental, social well-being of women, children, and their families, to ensure that the pregnant woman and her unborn child are in the best possible health prior to delivery. And for doctors, it is enabling them to identify women with specific health and social needs, risk factors including those that can potentially be addressed before at the booking appointment, for example, smoking, hypertension, and so on. Now, the first antenatal visit should take place as soon as possible, patient when she misses a period, preferably by 10 weeks of pregnancy. And if she's coming late, we must inquire the reason why, because it may reveal social, psychological, and medical issues. As per our COG, we planned 10 routine antenatal appointments for nulliparous women and 7 for parous women. And according to WHO, and ideally 8 visits should be there. So, but we have to understand that additional or longer antenatal appointments would be needed depending on the woman's medical, social, and emotional needs. And involving the partners during the antenatal visit according to woman's wishes, and to let them know that she is welcome to bring her partner during appointments and during any sessions they are being given. Now, the first antenatal appointment is so very important, and it assesses the medical, obstetric, and the family history, the current or previous mental health concerns, current or recent medications, even the over-the-counter medications or Ayush medications that she has taken, any allergies. We shouldn't miss out on them because sometimes mishaps do occur, which may be very serious ones, and to be highlighted in her records. The occupation that she's pursuing, what is her home situation, what is her lifestyle. We need to review the previous medical records, if any, because patients, they tend to forget or to, not give that importance to their conditions, which a doctor may, give it the due importance. So here I must bring in the inverted pyramid of antenatal care. It is a shift from the traditional approach. Instead of increasing surveillance as pregnancy progresses, it focuses on early interventions and individualized care. The first trimester screening, whether it is for aneuploidy or any anomalies, it is very important in this period. Most fetal chromosomal and structural abnormalities, many of them can be diagnosed early, and combined tests can play a crucial role. So what we are doing here is risk stratification, identifying pregnancy at high risk for complications. A personalized care plan can be developed with more intensive monitoring, those who belong to the high risk groups, and not so aggressive monitoring in the routine cases. Early detection and management of conditions like preeclampsia, small for gestational age, diabetes, mellitus, all these can be looked into. Treatment can be initiated in the first trimester itself, which can reduce the incidence of certain disorders or their complications. So this is what that inverted pyramid is. Here the evaluation initially, traditionally, the care would begin at 12 weeks, and the frequency of our monitoring would increase as the pregnancy progressed, from once a month to twice a month to every week. But now it's a bit different. In the initial visit itself, a thorough evaluation is done through history, through examinations, through investigations, so that they can be, stratified, and those needing specialized care can have a more vigorous monitoring, and those belonging to the low risk can have not so many antenatal visits. So when the patient comes to us, not only the history, it's also we have to also examine the patient, measuring her height and weight to calculate the BMI. Apart from other examinations like her blood pressure, her blood pressures, her abdominal examination, pedal edema, the routine things that we do every time that she comes to us. Now, there are certain lab investigations which we'd be doing very early on, like the complete blood count, not just the hemoglobin, but a complete blood count is what we are looking at. The ABO and RH we have to know for each of our patients. The urine analysis, including cultures, rubella, hepatitis B, C, HIV, other STIs, if she belongs to the high risk, especially the VDRL, which again is a routine examination. And more recently, tuberculosis is also being included in that list. So what are these screening programs that we have to follow? The infectious disease screening programs like the HIV, syphilis, and hepatitis B and C, the sickle cell and thalassemia screening, we should not overlook them, the fetal anomaly screening programs, assess the risk for preeclampsia and advise those at high risk to take aspirin, risk assessment for diabetes, deep vein thrombosis, anemia. Consider assessing for cardiac conditions if there are concerns, because we get the insight through our history taking and also examining the patient, and a risk assessment for growth restriction, where a history, the profile of the patient, and again, ultrasound, the uterine Dopplers and all, they come into play, and also a clinical examination of doing an abdominal, serial abdominal fundal height. So in the first trimester, like I mentioned in the inverted pyramid, it is so very important because we can, get an insight to so many things. So the aneuploidy screening for the first trimester, we have the biochemical HCG and the PAPE, the nuchal translucency, but best would be the combined test dual marker plus NT, and nowadays NIPT is coming in a big way. So collection of blood for biochemical analysis is performed between 9 to 13 plus 6 days, and the crown length being 24 to 84 millimeters. But then nuchal translucency, the first trimester NT scan is so important. NT alone can approximately 80% of Down syndrome and other major aneuploidies with a false positive rate of 5%. A combination with the serum markers improves the detection rate to 90%, and detection rate can increase further to about 95% with a false positive rate of 3% by examining at the same sitting nasal bone, ductus venosus, and the tricuspid view. NT alone is used as a marker only in screening multifetal gestations, in which serum screening is less accurate. In twin pregnancy, aneuploidy detection rate is at least 15% lower than in a singleton. Now, sometimes the first trimester is missed because the patient did not come to us, or she was not in a place where it could be offered to her. Then second, we have to go for second trimester screening. Though it has no advantage over the first trimester screen and used only when the first trimester is missed out. The quadruple screening is done between 15 to 20 weeks. Here we are doing the alpha-fetoprotein, HCG, the HCG, alpha-fetoprotein, and just it's slipping my mind. Okay, it detects 81% of trisomies 21. But then NIPT is something which we have, something new that has been added. The prenatal genetics screening, the serum screening with or without NT, or that is the cell-free DNA, and diagnostic testing by CVS or amniocentesis options, they should be offered to all patients regardless of maternal age or risk of chromosomal abnormalities. Patients should have one prenatal screening approach and not a multiple of screening tests. You do this, and then if one screening test is positive, then we have to go for diagnostic tests. Now, cell-free DNA is the most sensitive and specific screening for common fetal aneuploidies, and all patients should be offered a second trimester ultrasound for fetal structural defects. Patients with a positive test should undergo genetic counseling, a comprehensive ultrasound, and an opportunity for diagnostic testing to confirm the results. Now, patients who have a negative screening test substantially decreases the risk of the aneuploidy, but does not ensure that the fetus is unaffected. Now, if on NIPT we get a no-call result, we have to understand that it may be associated with an increased risk of aneuploidy, and further genetic counseling, USG analysis, and diagnostic testing may be needed. If we have an enlarged NT or an anomaly on ultrasound, then genetic counseling again and a diagnostic test is needed. A comprehensive USG at 18 to 20 weeks to assess for structural abnormalities should be offered to all the patients. So, NIPT, the cell-free DNA testing as a follow-up for patients with positive serum screening test result is an option for patients who want to avoid a diagnostic test by CVS or amniocentesis because we know it can be invasive. It is invasive and patient may not be liking that. If isolated soft USG markers are present and aneuploidy screening tests or NT tests, there are low risk, then no further assessment is needed. However, if isolated USG marker is positive and no prior aneuploidy screening has been done, then we have to counsel them regarding the risk of aneuploidy, and we can offer them any of them, either the quad screening test because they're already in the second trimester, amniocentesis, or NIPT after counseling. No method of serum screening is as accurate in twin as in a singleton pregnancy, and cell-free DNA screening can be performed in twin pregnancies. The prenatal screening and diagnosis should be offered to all patients regardless of their risks, their age, and to add to that, pre-implantation genetic testing if it has been done in an IVF. So the other ultrasounds, like we have already talked about the 9 to 14 weeks ultrasound, that is the NT scan, which determines not only the gestational age, but detects multiple pregnancies, and also some of the malformations and aneuploidies can be identified. Now, USG at 18 to 20 plus 6 weeks or 22 weeks. For fetal anomalies, we can look for the fetal soft markers, determine the placental location, and many of our sonologists are now also mentioning the cervical length because we know it is a marker for preterm labor. Now, regarding third trimester, routine third trimester screening, now there are various guidelines saying something. Some are not routinely going for third trimester scans, some are advocating it, but we know for high risk we would be needing, and more societies are going for a third trimester or the growth scan. Now it can assess the fetal viability, presentation, anatomy. We know that some of the malformations they develop much later, even the growth, amniotic fluid volume, placental localization, and fetal placental Dopplers. Now, a screening, a monitoring should also be directed to us venous thromboembolism. We have to assess the risk factors in the first appointment through a vigorous history, and also after any hospital admissions or significant health events during pregnancy, because we know any immobilization can make the patient prone. We have a whole list of high risk for VT, the weight, the BMI, previous history, family history, certain medical disorders. So all those have to be noted. And what to say of gestational diabetes? We know we are, as an ethnic group, we come under the high risk, and we have to test all our pregnant ladies for diabetes. We have to do this in the first booking visit, and those who are negative, we again would have to repeat the test between 24 to 28 weeks of pregnancy. And of course, anytime it's positive, we have to manage them as a positive GDM case. What test to do? We can go for OGTT or after 75 grams of glucose, or we can do a single step test, that is DIPSY test, where irrespective of the last meal, 75 grams of anhydrous glucose is given in a drink, and after 2 hours, blood sugar is taken, and anything more than 140 is taken as positive. So preeclampsia and hypertension are just as important. A risk assessment for preeclampsia at the first antenatal appointments is done, and those at high risk are given aspirin. We have to measure blood pressure at every routine appointment using a device that is validated for the use in pregnancy. And we all know the nitty-gritty of taking an accurate blood pressure. The urine dipstick test for proteinuria at every routine antenatal visits. Now we have that gestosis score, and we know all the important histories that should be included in the risk assessment. More recently, there are other things that have come into vogue, a combo of maternal risk factors, the mean arterial pressure, uterine artery PI, and a PLGF, that is placental growth factor, or in the first earlier, and if PAP-A has been done, we can use either of the two. All these things can give a good risk assessment in the first trimester itself. For the second trimester, we also not only for high risk assessment, but also prognostication, we have now at our hands a ratio of soluble FLT and PLGF at our disposal, which many of us are using, though it's not though it has not come in some of the as guidelines in many of the recommendations. So in normal pregnancy, MAP decreases, while in preeclampsia it increases. Uterine pulsatility increases in preeclampsia. Placental growth factor decreases. PAP-A decreases, and the ratio of soluble FLT by PLGF increases during preeclampsia. Now, what about growth restriction? Now, risk assessment of fetal growth restriction again starts at the very first appointment. And again, we have to do it serially. In the first appointment, all the history is so important of the past, of the medical, of this pregnancy, family history. All those are the BMI, everything is important. Again, in the second trimester, we have the ultrasound. We have the uterine, like we said, the uterine artery PIs. So all those become very, and not to forget our own fundal height measurement serially. So of a fundal height, some symphysial fundal height measurement at each antenatal appointment after 24 weeks for a singleton pregnancy, unless of course they are being followed up by a serial ultrasound, then this becomes a sort of redundant. Then we have to plot the measurements onto a growth chart. For high risk, of course, we have to do scans and Dopplers serially after 26 to 28 weeks. We also have to ask the mother about her concerns for baby's movements at each antenatal contact after 24 weeks, and advise her to contact the maternity services at any time of day or night she notices reduced fetal movements after 24 weeks, and ask her to avoid going to sleep on her back after 28 weeks of pregnancy, as there may be a link between going to sleep on her back and stillbirth rate in late pregnancy. Of course, anemia, the omnipresent thing that we have with us, hemoglobin less than 7, not only the hemoglobin, but even looking at the patient, the Palmer, the conjunctival pallor, or if she has pallor plus a respiratory rate of more than 30 per minute, if she tires easily, breathlessness, etc., they all indicate towards severe anemia. Then again, we have the various grading that we need, and we know we have to screen for anemia in patients in every visit, in every trimester. So now regarding the appointment at 28 weeks, we know here some investigations have to be repeated, like the full blood count, the blood antibodies, Anti-T prophylaxis for Rh negative, that's why we'll be going for the antibodies. Again, for blood sugar, urine analysis, and of course, ultrasound, whether or not we have to decide. Now, screening for preterm labor, again, we have to do a risk assessment by history in the first trimester itself, a past history of preterm labor or from low birth weight. There's so many other things, infections and all that, bleeding in the first trimester, twin pregnancy, they all come under the risk assessment by history. Singleton pregnancy and a history of prior spontaneous preterm labor. Here we will be doing a routine TVS for cervical length measurements between 16 to 24 weeks. Routine TVS for cervical length is not indicated though in those who have undergone cervical cerclage, those with multiple gestation, those with PPROM or placenta previa. These are not routine. Cervical length screening for preterm labor has to be in selective population with high risk of preterm labor. Even though we get mid-trimester the anomaly scans with cervical, I think I find it quite reassuring. Though even though the guidelines have not made it a mandatory thing in the low risk. Now, regarding third trimester ultrasound to do or not to do, there are no clear-cut guidelines as of now. The anatomical examination may be technically easier. One thing is to do or not, of course, in a routine way in low-risk patients. Of course, in high risk, we would be doing multiple of them. But in a low-risk patient, first is to do or not to do, and then what is the ideal time to do it? The anatomical examination may be technically easier at this stage at 30 to 34 weeks, though we have sonologists here in the webinar with us and they'll be throwing more light on it. So anatomical assessment best at 32 to 34 weeks. Now, detection of growth deviation, both SGA and LGA in low risk cases may be more accurate towards 36 weeks of pregnancy. So timing should be decided based on individual maternal and fetal characteristics, the risk level of the pregnancy and local objectives and resources. Anatomical evaluation may be undertaken and should target examination of the head, brain, heart, chest, abdomen, and urinary system. We know that some of these develop or they're more identifiable towards the later time. Deep vertical pocket is of the liquor is preferred over amniotic fluid index for diagnosing isolated oligohydramnios as it is associated with fewer inductions of labor. Women with major placenta previa or a uterine scar may be offered a scan at around 28 weeks, while with minor previa may be assessed later. These are some of the pictures taken from the net. So another thing that we get is a vaginal discharge. Vaginal swab for pregnant women with symptomatic vaginal discharge. If there is doubt about the cause, then it may be taken. If a sexually transmitted infection is suspected, consider arranging appropriate investigations. Offer vaginal imidazole to treat vaginal candidiasis in pregnant women. And consider oral or vaginal antibiotics to treat bacterial vaginosis in pregnant women. We know they may also, be predisposed towards preterm labor and infections. Now, the importance of our clinical examination never ceases, Perform abdominal palpation at every appointment after 30 weeks for singleton pregnancy. If a non-cephalic presentation is suspected, we have to perform an ultrasound to confirm the presentation. For women with an uncomplicated single pregnancy with breech or maybe transfers confirmed after 36, we should rather explain to the patient about the external cephalic version that makes vaginal birth more likely and to offer this procedure if the patient is willing. Now, information for shared decision making, because we know patient is in the center of our care. We have to offer one-to-one or couple-based counseling, supplemented by group discussions, supplemented by written information in a suitable format, for example, digital, printed. Then we also have to, this has to be offered throughout the woman's care. It has to be individualized
ma'am.
and sensitive.
Meena ma'am,
Yeah.
if you could just speed it up, it's been half an hour.
Sorry. Okay, then that's my conclusion. So, a minimum of 8 visits, detailed history, all the investigations. So, thank you all. Sorry for exceeding my time.
Thank you, ma'am, for that wonderful presentation. I request the chairpersons to please offer their remarks.
Thank you, Dr. Meena, for that wonderful presentation. I have just two questions. One thing is, you talked about rubella investigations during antenatal period. We usually go for rubella during preconception counseling. During pregnancy, we usually go if the patient is symptomatic. And the other thing is, please explain how frequently urine culture sensitivity should be done during antenatal period, in each trimester, or how you do with your patients.
First, coming to rubella, yes. In fact, many of the things that I mentioned in the first is we could have it in the pre-pregnancy, all the more better. Because here we can actually, those who are negative, we can give them the vaccine and all that.
Yeah.
So that is absolutely, you're right. In some of the countries now, they have even taken it off their investigation list.
Our vaccine is also same.
Yeah. And the second part, madam, you said how free, yes. Okay. Now, minimum of each trimester, we have to go, we should rather, as of now, go for urine culture because we know of the asymptomatic bacteriuria. But dipstick we are doing in every. And depending on symptoms or anything positive in our dipstick, we can make it more frequent. However, one article I was reading recently which said that all those tests, asymptomatic bacteria and all the studies are very, very old. And I think some more recent studies can actually tell us that we have to probably validate these even with some more recent studies, I guess.
Thank you so much. Thank you.
Thank you, ma'am. Moving on to the next session, which is guidelines for antenatal monitoring. We have Dr. Sujit sir as the speaker. I would like to firstly introduce the chairpersons of the next session. Yeah. So the first chairperson is Dr. Geeta. Madam is a senior consultant at Mother Hospital, Thrissur. She's the president of Thrissur OB-GYN Society. She's also the editor of TOGS Monthly Bulletin. And she is also the faculty for the EMOCALS Quality Standard and ORRT training team. She is an UG and PG examiner. Ma'am, welcome to today's session, ma'am.
Thank you so much. Thank you.
Next, we have with us Dr. Datta Panindarkar sir. So, sir is actually, he's completed his MD from Grant Medical College, and he has completed his diploma from the National Board, New Delhi, 1992, and he's been the General Secretary for Grant Medical College Student Association. He is also the president of IMED Thane in the year of 2015 to 2018, and he has been he's currently the vice president of TOGS and also currently the member of Foxy Violence Against Doctors Cell and also
he
current
is the
member
president.
of Foxy.
He's the president, Sujaya. He's the president of Thane Society.
Okay. So, sir is currently the president of Thane OB-GYN Society. Sir, welcome to today's session, sir. It's an honor to have you with us. And we have Dr. Sridevi Velanki, ma'am, who is a consultant OB-GYN at Sri Vijaya Maternity Hospital at Vijayawada, Andhra Pradesh. She is currently the president of Vijayawada OB-GYN Society. She has been previously the vice president of Vijayawada OB-GYN Society in the year 2023-24 and also a secretary for the year of 2003 and 2004. She's been the first lady honorary secretary for IMA Vijayawada and also the vice president of Vijayawada. Ma'am, welcome to today's session, ma'am. I would request, ma'am, I would request one of the chairpersons to please introduce the speaker, Dr. Sujit, sir.
Okay. Dr. Sujit Kondkar is a director, Shri Hospital, Foxy recognized, which is a Foxy recognized USG training center. He's interested in advanced fetal ultrasound and fetal interventions. He's a member of ISUOG, past chairperson, Fetal Medicine Committee, AMOX, Vice President, Society of Fetal Medicine, Marathwada chapter. He's FMF certified for 11 to 13 week scan, preeclampsia screening, Doppler ultrasound, and fetal abnormalities. And he has done his basic invasive procedures training under Dr. Purana Sir's Apex Institute. Over to you, Dr. Sujit, for your presentation.
Thank you, ma'am, for nice introduction. I'll share my screen now. Yeah, at the outset, I would like to thank Program Coordinator, respected Dr. Asha Jain ma'am, and Convenor Dr. Sujayasri Sangita ma'am. So my topic is very vast topic. Actually, I have to make it very short. Just like instead of playing 5-day test match, you have to finish it in 2020 cricket. So what are the goals of screening? To triage mothers to low risk and high risk, to prevent maternal complications, to screen the fetus for chromosomal abnormalities, structural defects, and growth abnormalities, and decide the time and mode of safe delivery. This is a very comprehensive slide. Then, as Dr. Meena ma'am has mentioned earlier, the model of ANC care has been inverted. Previously, it was thought that all the complications, most of the complications were seen at later part of gestation in third trimester. So the fetal and fetal surveillance and maternal surveillance was more focused on that period. But thanks to Professor Nicolaides, he has inverted this model, saying that some very important complications that occur in late trimester can be predicted in first trimester. So this inverted pyramid helps in dividing cases into high risk and low risk. So this journey starts from conception to early pregnancy, first trimester, second trimester, and third trimester. It is important to note that no guidelines say that this and this sonographies should be done in pregnancy. Number of sonographies, there are nothing, nobody has been highlighted. But by and large, if patients are comfortable, then at least 5 sonographies should be done with many people's consensus. One sonography at 8 to 9 weeks during early pregnancy, then most important 11 to 13 weeks scan first trimester, then around 22 weeks mid trimester normal scan, one growth scan at around 32 weeks, and very important third trimester scan, which is called as growth scan as well as a Doppler scan at 36 weeks. The importance will be told in forthcoming slides. So pregnancy, early pregnancy till 10 weeks. What are the goals? To look at the normal appearance of gestation sac, yolk sac, and embryo, assessment of mean sac diameter and CRL, and viability criteria. So you must know the order of appearance of these things in early pregnancy. So first to come is intradecidual sac sign, then double decidual sac sign, then yolk sac, fetal pole, cardiac pulsation, and amnion. Remember that if this order is changed or broken, the pregnancy results in non-viable pregnancy or abnormal fetal outcome. So first to come is gestation sac. It is a very small, tiny 2 millimeter sac seen away from midline. It is not in the midline, away from midline. Next is double decidual sac sign. Remember that this sign may not be seen in 30 to 35% of patients. And yolk sac, appearance of yolk sac is very, very important in pregnancy because it confirms the intrauterine pregnancy. The normal diameter is 2 to 6 millimeter. Anything more than 6 millimeter is supposed to be a abnormally large yolk sac, and which may be associated with abnormal outcome. Cardiac flicker is seen at around 6 to 6.5 weeks, or whenever you see fetal pole, cardiac flicker should be seen at that time. And this is a beautiful example of diamond ring sign seen at the very small fetal pole. Amnion comes last at close to 7 weeks, and this membrane surrounds embryo which is thinner than yolk sac. So this is the order of appearance that should be known to everybody. Then 3 important measurements in early pregnancy. These are mean sac diameter, crown rump length, and fetal heart rate. So mean sac diameter is the mean of 3 orthogonal planes: longitudinal plane, anteroposterior plane, and transverse plane. On a normal, healthy growing pregnancy, the rate of growth of gestational sac is about 1 millimeter per day. And one important message I want to give here is do not use mean sac diameter for dating of pregnancy. Just measure the mean sac diameter and forget. Don't use it any further use. Then this is the most important measurements, crown rump length. This is used for dating of pregnancy, and so many things in pregnancy and ANC depend on correct CRL and correct dating, like advice of double marker test, advice of quadruple marker test, timing of invasive procedures, timing of scans, growth scan, and etc. So this criteria should be known to each and every person doing sonography. Fetal heart rate, and again, measurement of fetal heart rate, very important message. Whenever you are using fetal heart rate in pregnancy, early pregnancy, always use M mode and do not use power Doppler because safety is questionable. Fetal heart rate should be seen after the CRL 2 to 4 millimeter. In the early part of gestation, it is somewhat on lower side as shown here, up to 100 and 115. But at 8 weeks, it is 140 to 170. And after 9 weeks, it settles to 137 to 140 beats per minute. So you should know the criteria for pregnancy loss. Definite criteria I'm going to tell just. It is these are two criteria, CRL based and mean sac diameter based. So CRL based criteria says that whenever the CRL is 7 millimeter or more, and if you don't get fetal heart rate in that, you can straightaway label that pregnancy as a non-viable pregnancy. No need of follow-up scans. And when mean sac diameter is 25 millimeter or more, and you don't see any embryo with fetal heart cardiac activity, straightaway you can label this as a non-viable pregnancy. The parameters below 7 millimeter CRL and 25 millimeter MSD, you need to give follow. So now coming to first trimester, that is 11 to 14 week scan. So ISWAG has put very nice guidelines about that. So what are the goals? To confirm viability and plurality, accurate dating, screening for aneuploidies, identification of major structural anomalies, screening for preterm preeclampsia, and in some patients, when there is history of previous cesarean section with anterior placenta, screening for PAS, that is placenta accreta spectrum disorders, and screening for preterm labor, just discussed in last talk. So confirming viability and purity and looking for the integrity. See, you have to look whether the fetus, whether it is multiple pregnancy, and if it is twins, then you have to look whether it is diabetic or monochorionic. This twin peak sign or lambda sign is seen in dichorionic pregnancy, and T sign is seen in monochorionic pregnancy. ISWAG also state that you should know the integrity of the gestation sac. All that should be surrounded from all sides by myometrium. Then coming to fetal biometry, CRL just has been discussed in previous slides. All these BPD, HC, AC, and FL. This will be discussed in second trimester, but it is important to know that at 11 to 14 week scan, CRL is the most important structure, but you have to measure all this also, because it is said, it is supposed that you have measured, you have seen it, because many times what happens in hurry, you just take CRL and forget all, don't look at the other things, and here in hurry you are missing some cases of anencephaly. This is the list of. Next is fetal anatomy. This is very, very important because more than 50 major congenital anomalies can be diagnosed at this stage of pregnancy. This is very, very important. And this is a list of things which should be seen. ISWAG has come with two guidelines. One is minimum requirements, that means for newcomers, minimum things which should be seen at this stage. And best practice means more detailed study. So we should always go for best practice after learning minimum requirements. For example, in the head, you have to go for two important sections. This is butterfly sign, two cordoplexus with intrahemispheric line, then transthalamic view. This one, then the aqueduct of Sylvius with this fourth ventricle. This parasagittal view of the head gives very great information. You can visualize nasal bone. You can measure nasal nuchal translucency. You can see the palate here. This is double line with the palate, and this midbrain, thalamus, and three important regions and two lines, that is intracranial translucency can be seen. Coronal plane, you can have this prenasal triangle as well as two orbits. You can look the integrity of this. You can look at the echogenicity of the lungs, then fetal heart, duocardia, then two when putting in color 2 lines in diastole, it confirms the in and out flow of the atrial ventricles and 3 vessel trachea view. And also, ISOAG also has stated that you have to look for left ventricle output tract also. And importantly, rule out tricuspid regurgitation. For that, one tip is that whenever you are measuring fetal heart rate in this stage, in 11 to 14 week scan, always put your cursor at the tricuspid level. You get 2 informations. One is fetal heart rate, another is you come to know if there is any tricuspid regurgitation. Then abdomen, 2 or 3 cystic structures. One is stomach, second is this urinary bladder. You look at the cord insertion to know whether is there any any omphalocele or gastroschisis. Put color in that, and you see the umbilical cord encircling this bladder, suggesting or ruling out single umbilical artery. And for spine, you have to look at parasagittal section as well as coronal section. And for extremities, you have to look for all 3 segments. So this is the whole list. It is very difficult to describe everything as we won't have much time. Then next important thing which we know in this scan is tools of aneuploidy. So you measure nasal nuchal translucency, nasal bone, and this measurement of ductus venosus and tricuspid regression. You see, with the help of these tests, combined test with nasal bone plus tricuspid flow and ductus venosus flow, the detection rate of Downs is up to 95%. It is very, very high, and very less false positive rate, that is 2.5%. Assessment of risk factors, for example, scar pregnancy and placental abnormalities. So whenever there is implantation of gestation sac in lower uterine segment, you have to look for the features of scar pregnancy. These are very important 4 features of scar pregnancy: empty uterine cavity, empty cervical canal, gestation sac at previous scar site, this site, and very, very thin myometrial anteriorly, like shown in this figure. Then placental abnormalities, look at the placental ischotexture, masses, any multiple cystic spaces are there, and any large subcoronary collection. The distance of lower edge of lower margin of placenta and the internal loss is not much discussed at this stage, because most of the placenta are in lower uterine segment. We are waiting for more growth to happen in latter part of gestation. Now, screening of preeclampsia, all of us know this Bayes theorem. The final risk is given by adding maternal history, a priori risk plus biophysical markers, that is measurement of blood pressure and uterine RT-PI and biochemical markers. So measurement of uterine RT-PI is the most important thing which is done at this stage. One important thing I want to highlight here: measure uterine RT-PI from 11 weeks onward till the end of pregnancy. In each and every scan, you have to measure uterine RT-PI and see the detection rate with mean uterine PI, PLGF, and mean arterial pressure is very high, more than 90%, as shown in this graph. And how to measure it? Make a sagittal section of cervix, tilt the transverse to right side with color on, you will get right uterine artery. To left side, you get left uterine artery, and put the cursor on that. Now coming to mid-trimester ultrasound scan. Along with all these goals, cardiac activity, fetal number, fetal size, anatomy, placenta appearance, amniotic fluid, and measurement of cervical length, the most important objective or goal of this scan is to look at the structural survey. It is called as anomaly scan, it is called as TIFA scan, but it should be done at around 20-22 weeks. Now coming to fetal biometry and well-being, you have to measure biparietal diameter, head circumference, AC, and FL. These are the basic biometrical measurements should be measured from 11 weeks onwards till end of pregnancy. And dating should be done when it is not done previously. And here, after 14 weeks, you do not go for CRL. You use head circumference and or FL. Remember that HC is far better criteria than BPD for dating of pregnancy. HC and FL, they should agree, or only HC you can measure. And these are the criteria for measurement of blood pressure, BPD and HC. This is axial plane. You can use in transthalamic plane as well as in transventricular plane. This is how outer to outer diameter you can use, outer to inner you can use. My current recent ISOC statements say that outer to outer diameter should be undertaken, but it depends on what chart you follow. You should follow your chart, which is constituted in your reporting software or ultrasonography machine. Abdominal circumference, again, a transverse section of fetal abdomen, which includes fetal stomach and this umbilical vein. It can be taken two ways, either eclipse or anteroposterior diameter and transverse abdominal diameter. Femur length, again, it should be imaged at the both end of ossified diaphysis. You should not measure spurs or distal femoral epiphysis in that. Then estimated fetal weight. Most of the machines, most of the softwares, most of the reporting softwares use Hadlock 3 formula, which includes head circumference, abdomen circumference, and femur length. Always use centiles when you are discussing estimated fetal weight. This fetal weight falls on this and this centile for this gestational age. There are no specific parameters for anything in pregnancy. And always use growth charts, which helps you detect the growth abnormalities. Amniotic fluid assessment. You can start amniotic fluid measurement or amniotic fluid index after 18 weeks. Two ways are there. Amniotic fluid index like in 4 quadrants or single SDP, or which use a single largest pocket. In amniotic membranes, they are separated before 16 weeks, but after 16 weeks, they should be fused. If they are found not unfused even after 16 weeks, there are some complications associated like amniotic band syndromes, premature delivery, or even intrauterine fetal demise. And you should look at fetal movements also. You should be familiar with normal fetal movements. Any abnormality in the fetal movement or restricted movement may lead to diagnosis of arthrogryposis. Biophysical profile is not considered part of this mid-trimester scan. An umbilical cord, you have to look for the marginal or filamentous insertion, that is insertion of umbilical cord into membranes. And next to another is single umbilical artery, which is diagnosed when you put in color at the cord insertion site, when two vessels encircle the bladder. In single umbilical artery, you can see only single vessel like this, and it is associated with congenital anomalies and fetal growth restriction, especially in twin pregnancies. Doppler, there is currently insufficient evidence to use of routine Doppler at mid-trimester 20-22 week scan. But as I already mentioned, measure uterine artery PI in each and every patient. In selected rare cases of early FGR patients, where everything is disturbed, you can use umbilical artery and all rest of scans. Color Doppler is used in this stage, at this stage of gestation, to look at the fetal heart and cord vessels. Now coming to anatomical survey, this is very, very important. Head, these three planes, transventricular plane, transthalamic plane, and transcerebellar plane. And for the face, in the coronal section, you have to look at the upper lip, lower lip, nose, and chin. Then you have to look at the both orbits and lips. Then in sagittal section, you have to look at the frontal bossing, nasal bone, upper lip, lower lip, and this part of the palate and chin to rule out micrognathia. Neck masses, you should neck. It is the obvious thing you should be seen when umbrella of amniotic fluid is there. You should look for the neck masses like cystic fibromas, goiter, or teratomas. Thorax, you have to look whether texture of lungs, any masses like CPAM or sequestration or CDS like things. See here, it is beautifully, diaphragm is very beautifully shown in this image. Then fetal heart. There can be a 3-day conference on fetal heart, but important things, 5 important things to know. One is leocardia, that is fetal on heart side. Then 5 important things are 4-chamber view, left ventricular outflow tract, right ventricular outflow tract, and 3-vessel view and 3-vessel trachea view. These are the basic minimum things that should be seen at fetal heart at this gestation. Abdomen, then look at the cord insertion, look for any omphaceal or gastroschisis, look at the stomach bubble, 3 cystic structures, stomach bubble, urinary bladder, and in some cases, look at the gallbladder. And both kidneys should be present. Urinary bladder should be, there should be some fluid at any time in urinary bladder. There should be some fluid. And this is the measurement of pelvises distribution. Kidneys, pelvises should be always measured in transverse section, not any other parasagittal or sagittal section. The skeletal for spine, you have to look the spine in parasagittal section as well as in coronal section, and you have transverse sweep from neck to sacrum region. And for extremities, you have to look all the 3 segments from upper extremity as well as lower extremity. That means humerus, radius, and hand, and femur, tibia, fibula, and feet in each and every patient. Look at the placenta, any hemorrhages, masses, and cysts, and distance of inferior margin from the internal os. That helps in many cases to look seriously in forthcoming weeks. The cervix, vasa previa, when you put in color at the level of internal os, you diagnose. It is very easy to diagnose vasa previa. And cervical length, as discussed in last slide. So you have to decide whether you should start progesterone or cervical. Go for cervical and cerclage. Now coming to third trimester, these are the ISO guidelines in third trimester. So the indications are viability, presentation, anatomy, growth, amniotic fluid volume, placental location, Doppler, assessment of gestational age, and multi-pregnancy. There are two schools of thought. At what gestation it should be done, at 32 weeks or 36 weeks. At 32 weeks, you get to know anomalies better because the amount of liquor is relatively larger as compared to 36 weeks. But the most important indication of third trimester scan is diagnosing growth disorders, especially late FGR. You are going to diagnose late FGR only and only when you are doing sonography at 36 weeks. So it's my appeal to each and everyone, don't miss this 36 week scan. You are going to diagnose late FGR only in this scan. Remember that a baby can be AGA, appropriate for gestation at 32 weeks, but it can land in FGR at 36 weeks. And this late FGR is responsible for more than 40% deaths in third trimester, which were labeled unexplained in previous years, in past. Fetal anomalies, these are called as late onset anomalies. There are two important reasons. One, they might have been missed because of some technical difficulties like high BMI or unfavorable position of the baby. And in some cases, their natural history tells that these are seen only in third trimester. Some anomalies can be seen after delivery also. So many deliveries like GUT, CNS, and CVS, they are seen in late trimester. But benefits of diagnostic anomaly in this session are there. You can counsel the parents regarding this, so they are prepared for birth of an anomalous baby. Genetic study, you can do amniocentesis at this period also to confirm diagnosis, and in selected cases, you can think of termination also. So for examples of late onset anomaly in head like microcephaly, ventriculomegaly, disorders of cortical development, agarria, pachygyria, and vein of Galen. And in fetal heart, obstetrical lesion like coarctation of aorta, stenotic lesions are seen. Remember that fetal heart, there is a slight right ventricular dominance, and so right ventricle diameter may be slightly larger than left ventricle diameter. In chest, you have to look for space occupying lesion. For example, 20% of CDS are detected only in third trimester. The defect is there since start, but only in third trimester, the contents of abdomen viscera go into thorax. For abdomen, look at fluid collections, calcifications, cystic structures, and buoyant dilatations. And in urinary system, it is very, very important. 60% of hydronephrosis cases are detected only in third trimester. Placenta previa, look, whenever you are suspecting placenta previa, when the sonography is done in previous scan, it is suggestive of low-lying placenta previa. You can use transvaginal scan. It gives much more information because the presenting part head will obscure the finding. Gentle transvaginal scan will give you each and every important, the distance of that lower edge of placenta from internal mass will be clearly seen in these cases. The 20 millimeter is the cutoff given in most of the guidelines. And you have to look at the placenta acreta spectrums in selected cases where there is previous LACS or scar, and with placenta previa, especially anterior placenta previa. These are the grayscale imaging signs, and these are the color Doppler signs. The most important grayscale imaging signs are loss of clear zone and placental lacunae. And color Doppler signs are there is vascularity everywhere. Bridging vessels and subplacental vascularity. So here you can see here the clear zone is lost here. This is normal clear zone, and this clear zone is lost here. These are the subplacental vascularity. This is placental bulge into the bladder. And these are the lacunae, big lacunae filled with blood vessels. This is abnormal. This is suggestive of placenta acreta spectrum disorder. And vasopria, that is the that you can tell a spot presentation. The umbilical vessels traverse along with the internal loss. So this is having 100% sensitivity TVS with color Doppler. So you should know the risk factors: placenta previa, second trimester low-lying placenta, bilobe placenta or placenta with subcentrate lobe, and multiple gestation. In Doppler, coming to Doppler, it is having separate guidelines for Doppler. We should know what are the placental test and what are fetal test. Umbilical and uterine artery Doppler are placental test. They reflect fetoplacental and uteroplacental resistance. And fetal test are MCA, middle cerebral artery, and ductus venosus, which indicates response to hypoxia, adversity. So uterine artery tells you about trophoblastic invasion. Umbilical artery tells about placental venous obturator. MCA tells about brain sparing. Ischemia is losing its importance because the various studies are denying this, and ductal stenosis is telling you myocardial infarction. Now coming to growth abnormalities, LGA or SGA. So for that, your dating should be correct, your biometry should be correct. You use growth charts. Hadlock 3 is used. LGA is called when the estimated fetal weight is more than 90 centile. We call it macrosomia when it is more than 4 kg. And there are many complications associated with LGA. These are like shoulder dystocia. Then small for gestational age, when it is estimated fetal weight is less than 10 centile, it is called as SGA. And when it is associated with Doppler abnormalities, it is called as fetal growth restriction. We have various definitions for fetal growth restriction according to Delphi criteria, Delphi consensus. There are solitary criteria, and then along with other combined things. So screening for SGA or FGR is in general population is more accurate when the examination is performed at 36 weeks rather than 30 weeks. So 36 weeks ultrasonography with multivessel Doppler is very, very must, as I have discussed in last slides. And estimated fetal weight and abdominal circumference can be used to screen for SGA or FGR with similar performance. Here is one slide discussing importance of cerebral placental ratio. So normally at any gestation age, MCA PI is more than umbilical artery PI. So in hypoxia, umbilical artery PI goes up and MCA PI goes down. So CP ratio is the ratio of MCA PI to your umbilical artery PI. It has a greater sensitivity than assessing individually MCA and UA. So less than 5th centile is supposed to be abnormal. It is associated with adverse perennial outcome, and CPR can be abnormal even when individual PI, MCA, and umbilical artery are within normal limit. So importance of CPR should be kept in mind when you are looking at the fetus in 3rd trimester. Amniotic fluid vulnerabilities, either AFI, SDP, but whenever you are diagnosing or discussing about oligohydramnios, always use SDP because AFI overdiagnoses the polyhydramnios. So last slide, there is no consensus regarding number of scans, but at least these type of scans should be done in pregnancy, which I haven't discussed. Biometry and anatomical survey is the most important and constant element of each and every scan. And you should know important things to look in respective trimesters. Thank you for being online. And one important appeal for you, please support me for my candidature. I'm contesting for Chairperson Imaging Science Committee. Thank you. Thanks a lot.
So wishing you all the best for your candidature, sir. And it was a very nice presentation. I request the chairpersons to please give their concluding remarks. Dr. Geeta, Dr. Sridevi, and Dr. Neeta, sir.
Yeah, thank you so much, Dr. Sujit. That was an extremely compact but comprehensive presentation. I think no one can do better than that. And just one thing I just wanted to say is not everybody is doing the scans. So probably what we who don't do the scans or who depend upon the radiologist, probably what we probably should do is to have an extremely good rapport with our radiology colleagues or fetal medicine colleagues, whoever is doing it, and be clear as to what we want from them. So I think that is all I wanted to say. I don't have anything more to add because you have been very, very, very comprehensive. Thank you so much for inviting me for this, Dr. Asha.
Thank you, ma'am. Actually, one point I want to
It's a
highlight here.
pleasure seeing you smiling here. It's really great to see you. And my vision was that, Dr. Sujit would tell gynecologists what are the images they should look for when they see the report. You need to memorize those images, because if you are only looking at the reports, you are misguided. So that is why I told him that, you show the ideal images. And all gynecologists, whether they are doing the scans themselves or not doing it, they should look for those images. NT is done and the head is posterior, and you can't really see anything, and there is a report. So you need to know when to discard a report. That was the vision behind this. Datta, sir?
Yeah. Good evening. I think,
Namaste,
Dr. Sujit, it was a fantastic lecture. I think you have played the T20 even better than a test match. So thank you very, very much for your inputs. And one thing I wanted to ask you, which is a question which most people ask me, if the anomaly scan is done by a gynecologist, not by a radiologist, and say, God forbid, there is some anomaly which comes up after the birth of the baby, then medical legally, how safe are we? Means, are we medical legally
As
correct
safe
in doing
as
the anomaly scan, or we need,
we are entitled to do anomaly scan, no doubt.
so we are medically safe enough to do the anomaly scan.
Yeah, you are medical. I am doing everything. My students, actually, my center is Foxy Recognized Center. Those students who have passed or came out of my center, they are doing excellent anomaly scans and Dopplers. Growth
You know,
scans.
because in Thane we had a case about 6 months back where the anomaly scan was done by the gynecologist and the NT scan also. And when the baby was born, there was a huge meningomyelocele, probably which was missed. So
Yes.
what the patient complained was that why the scan was not done by a qualified sonologist rather than the gynecologist himself.
So this thing can be missed by radiologist also, senior radiologist
Exactly,
also.
and that is correct. But that is why this query.
So your degree is enough. You don't need any additional degree for doing sonography.
Right. Good. That's
we
what I
don't
wanted.
need the degree, but to be medico-legally safe, I would advise, please learn. Please learn before you start doing it. Because Dr. Sujit said his students are doing it. That means they have learned, right? We have all learned. I am doing it, but I have learned. I have completed my fetal medicine course. So before doing something, please learn. And then do it. And then you are safe.
Don't do it blindly.
We had a similar case in Kerala also.
If you are confident enough to do, please do make it in your practice. My suggestion is that just keep anomaly scan in your practice. Learn something in sonography. You can do early pregnancy scan, NT scan, growth scan. Even Doppler is also easy. Don't touch anomaly scan in your initial days of practice.
Correct.
Rest of things are quite easy.
Right. Perfect. Thank you so much.
And one more thing, Dr. Sujit. One more thing, Dr. Sujit. If we diagnose placenta accreta syndrome on ultrasound, do you recommend going for MRI or ultrasound is enough?
MRI is having slightly
higher specificity and sensitivity, isn't it? Yeah. Do you recommend if the patient can afford?
Yes.
Whether it is invading the bladder.
It is better to refer,
to have an idea before we take her up, isn't it?
Yeah, because all the signs are available on sonography report, all seen on sonography report. Because it is no dilemma.
So if the patient can afford?
Always go.
Always better to do an MRI.
Always better to go for, yes.
Afford, better to do it.
Yeah, better to do. You have one more additional thing to tell them. That increase the seriousness about the disease of for the patient.
Yeah. You need to send to a center where the MRI person knows how to report.
Yeah, that's also important.
Yeah, you are just sending it for MRI and the report is worse than what you are doing yourself.
Yeah,
so
that is also there. Yeah.
The reporting has to be has to be crucial.
Yeah, of course. And one more thing, Dr. Sujit, what about isolated soft markers like echogenic bowel, echogenic shadows in the ventricle?
Isolated soft markers, they don't carry any importance when they are seen in combination. For example, echogenic cardiac focus is seen along with URSA or along with some ventriculomegaly. These two are markers for down. You have to assess the risk, and according to that, you have to advise invasive testing for the patient.
And up to which trimester pulsed wave Doppler is not safe? Is it only in the first trimester
only
or
in the
later
early
on?
pregnancy.
10 weeks.
4 to 10
only
weeks.
Early pregnancy. Okay.
Early pregnancy use only M mode.
Okay, that was an excellent presentation. Thank you very much.
So that was a great presentation, sir, and I thank all the chairpersons for their involvement. Moving ahead, next we have our panel discussion. So I request Dr. Asha.
Just a second, Sujay, there's a question for Dr. Meena on YouTube.
Okay,
Meena ma'am, are you still there? They're asking, why do you want to do urine culture every trimester? That is the question for you on YouTube. Meena ma'am?
Ma'am, I have to answer it somewhere else, or do I?
No, ma'am, you can verbally answer.
No, you have to answer it just like this.
Okay. Okay, we are concerned about the asymptomatic bacteria that otherwise does not need treatment outside of pregnancy most of the times, and maybe a few other situations. So we know if there is asymptomatic bacteria and it remains untreated, that it may progress to frank UTI, pyelonephritis. So that is what we are concerned about. So that is why we are doing it.
Yeah. Thank you, ma'am. I hope that answers the question. Moving on to the panel discussion, I request Dr. Asha ma'am to introduce the expert and the panelists.
Thank you, Sujaya. So, we've heard everything there is to hear about antenatal examination. And now we just have specific situations and an overview where we are going to revise everything so that all the viewers can have it deep in their heads what needs to be done. And we have all experts here. So our expert for this panel is Dr. Uma Shankar. He's an MBBS, MS Gynae, Diploma in Lab Surgery, endoscopic surgeon, clinical head and infertility specialist. He is also the organizing secretary of 5th AMPOG and is the secretary of Guntur Society. Welcome, sir. I'm really honored to have you here with us, and thank you for joining.
Yes, ma'am.
Thank you, sir. We have Dr. Kiran Sonwalkar, our panelist. He has a past experience as a PCPNDT medical officer in Satara, and he has conducted PCPNDT workshops, worked as appropriate authority in Koregaon Rural Hospital for 2 years, my God. So welcome, sir.
Thank you, ma'am.
Sir is also the secretary of Satara Obstetric Gynec Society. We have Dr. Amrita Kumtekar, who's the secretary of Solapur Society. She's practicing for the last 15 years, and she's also passed her MRCOG Part 3 in first attempt. Welcome, Dr. Amrita. We have Dr. Samia Mufti. She had an ankle injury and has not been able to join us. She was the secretary of Srinagar Obstetric Gynec Society. She's a medical officer in Directorate of Health Services. We have Dr. Ujjwala Vardapurkar, who's the secretary of Thane Society, a very, very accomplished gynecologist, and she's been busy. She's just become busy in an emergency cesarean section, and so she will join us when she can. She has so many awards, and she's a member of very many associations, a very, very active Foxian and gynecologist. We have Dr. Uma Brinda Jaipal ma'am, who is the secretary of Thanjavur Obstetric Gynec Society, and her fields of interest are high-risk obstetrics and infertility. We have Dr. Monica Umbardan ma'am, who doesn't know Dr. Monica. She is the national coordinator for PAC committee. She's also the AMOG zonal coordinator, a dear friend, a very accomplished gynecologist. Welcome, Dr. Monica. Then we have Dr. Jigyasa Dengra, who's the secretary of Jabalpur Obstetric Gynec Society. She is director and consultant at Mahi IVF and Women's Center, Jabalpur. Welcome. We have Dr. Prerna Kishan, who's the East Zone coordinator for Foxy. She practices in Tinsukia, Assam. The one name you have to contact in the Northeast other than Priyankur. So welcome, Dr. Prerna. We also have Dr. Sujata Velanki ma'am, who's the secretary of Vijayawada Society. She's the former professor at Dr. PS Institute of Medical Sciences and Research Foundation. Her specialization is luteal support, low ovarian reserve, single embryo transfer. So she's a hardcore IVF person. Welcome, Dr. Sujata. I'm really honored to have you all here.
You, ma'am.
So now I would like to share the panel. So it's antenatal monitoring. No questions have been given to anyone. Anyone and everyone is free to speak and join in at any time. So please vote for me for Food, Drug and Medico Surgical Equipment Committee. The voting will be from 16th to 25th August. So now we come to the introduction. These are the introductory questions that we are going to have. In your practice, how often do you call your patient for antenatal visits? Supposing she comes to you with a urine pregnancy test positive. When do you call her and when should you call her?
Ma'am, in case of a low risk pregnancy, she should register to the hospital as soon as her pregnancy test is confirmed. After which we usually call her every 4 weeks till around she completes 28 to 29 weeks of gestation, following which, depending upon where she lives, we can call her every 15 days or every 3 weeks interval. But after 36 weeks, weekly NST is recommended, so she needs to follow up with the hospital every week in her last month of pregnancy. In case if she is a patient with bad obstetric history and has previous abortions, then I would like to call her more frequently, even in the first trimester, ma'am.
Okay. So now one basic thing is, when we say a low risk pregnancy, is it a prospective diagnosis or is it's a retrospective diagnosis?
Ma'am, I want to add on to
Yes,
here
ma'am.
that
Yes,
since
Prerna.
we have
Welcome.
asked the frequency of routine antenatal visit, actually it should be preconceptional visit. By the time the patient comes to us, they're already 5th week pregnant. So we always say that they have missed the preconceptional counseling. So every pregnancy on today's date should at least receive the preconceptional counseling prior to they become pregnant, rather than coming in the 5th or 6th week of pregnancy.
Oh, see, that is a very ideal situation, but even doctors don't report. Gynecologists don't report.
Don't report,
What
ma'am.
to say? Means I have gynecologists with 2 abortions, 3 abortions, and they have not even taken folic acid before they became pregnant again.
Very true.
So that is
Yes.
a really ideal situation that we should see that it happens, but I don't see it happening very soon in the future.
Ma'am,
So
your question, ma'am,
my
would be a
question remains
retrospective.
unanswered.
Ma'am, it would be a
Yes.
retrospective option.
Yeah. So low risk is always retrospective. Otherwise, what Meena Samant ma'am's first slide was there, that you don't know when it's going to become pathological. So you need to be alert and keep watching for something going wrong. Now, how important are nutritional interventions? When a patient comes to you, she's come to you for the first visit. So would you recommend any diet, anything when she comes to you?
Very much, ma'am. Medical nutrition therapy is the best mode of therapy for every ailment that revolves around pregnancy. And we should, on the very first day, make a chart of what she needs to eat, what she needs to avoid, all sort of junk, extra salt, pickles, and all these, and make a chart of a plating, how much carbohydrate, how much protein, how much intake should be in what percentage. That is very much required for a long-term well-being, as well as in the country with including like so much of GDM propping up every now and then. So we need to actually give her the MNT on the very first day.
Ma'am, in a
Dr.
place
Sujata,
where
would you like to add to that?
ma'am, in a place where I live, it's a rural place, so people generally do not understand the caloric requirements and things. So I give them a blanket advice saying that anything that comes packed from factories is to be avoided in pregnancy. Whatever you cook at home is the best for you, and follow better cooking principles like boiling and baking, or avoid deep frying. Avoid too much of cooking of vegetables because they will reduce the nutrition value. These also need to be given to the patient, because that is the main concern in rural areas.
Agree.
I would just like to
Yes,
add
Dr. Sujata.
this,
Yes, ma'am.
because I'm into fertility practice. So what normally happens is we, as Dr. Prerna was telling, like we have increased incidence of GDM in our population. So the nutritional interventions and counseling should start pre-conception again. But even if the patient comes to us at the first booking antenatal visits, we will give them a list of medications, we give them a list of diet instructions. Most of the times they tend to be confused. So they might not be able to follow up. An ideal advice is to give them a tracker and ask them to make a note of what they're actually eating, or give us a plan of what they have been eating before. So we will have a fair idea of what their staple diet is, and so we can give the recommendations, because here we are looking at improvement. Main thing that we are looking at is improvement in the folic acid supplementation and foods which are rich in iron and calcium.
Also protein, ma'am. In
Yeah,
India,
protein.
what we have is protein, energy, malnutrition, along with all nutrients. And now the diet that people have started eating out of internet also. You know, educated patients will come, they will be reading on the internet, and they have stopped eating their rice and dal, and they are into oats chilla and things, you know, which are weird, which are not native to you. So my recommendation, usually I would say that what your grandparents used to eat, you know, go back to that food.
And then also simple additions like using iron ore cookware would also increase the iron content in the diet, ma'am.
Yeah.
Also, there should not be a long gap between the meals that should be advised. Frequent small meals will give her more nutrition than, otherwise this NVP of pregnancy will crop in, and then she'll have that nutrition deficiency that can crop in.
Lots of fiber also needs to be included, ma'am.
There should
That is
be
salads and
nutritional-
vegetables.
There should be
Agree to
nutritional
Dr.
chart
Monica.
according to
Agreeing to
trimester
Dr.
wise.
Monica, in the rural setup, this blanket therapy for everybody to have home cooked food. We are also, Dr. Monica, in the most rural of Northeast, flooded all around. So it's really nice that you have put up this word that whatever is home cooked is good for them. Otherwise, they end up into having those junk from the market.
Anything that comes in package is not to be taken, is my blanket instruction to everything.
Nice, very nice.
Kiran sir, if you would just adjust
Yes,
your
ma'am.
camera a little so that I could see your complete face. Yeah. Thank you so much. Now, sir, this question is for you. What are the recommendations for use of ultrasound in the first trimester?
Mostly we advise ultrasound in first trimester to rule out position of the pregnancy. It is intrauterine or extrauterine, and if available, we judge the viability of the fetus. These two conditions are important in first trimester. There are different recommendations for government and private setup. In our Maharashtra government setup, they don't advise mostly the first trimester ultrasound. They directly advise second trimester ultrasound. But in private setup, most of the do the first trimester ultrasound for viability and position of the fetus and multiparity, rule of multiparity.
No, sir, but are they not doing the NT scan? And now, after hearing Dr. Sujit, don't you think that NT scan should be included?
Most of the government setup, excluding district hospital and government medical college, ultrasound facility is not available in rural hospital or primary health center. So it is not compulsory. It will be the optional for the patient to do NT scan in government setup.
Okay. So, what is the incidence of preeclampsia and GDM in different areas? So, Dr. Monica, I start with you, and I would ask everyone, what is the incidence of GDM in your area?
Ma'am, in Solapur, preeclampsia is more common as compared to GDM in our areas of Solapur in and around. And we are not having primary PIH because PIH is easier to maintain. We are having more of the complications of severe preeclampsia now, ma'am. Because here in Maharashtra, the mortality rate has reduced, the incidence of PIH has also reduced. but we are facing more of postpartum cardiomyopathy, severe preeclampsia, HELP. This is more common nowadays with us, ma'am.
Kiran sir?
Preeclampsia cases are diagnosed more than the diabetic cases because we do blood pressure measuring for each visit for ANC, but diabetic screening is comparatively less. So diagnosis of preeclampsia is more than the gestational diabetes, and prevalence also preeclampsia is more than gestational diabetes in our side.
Sujata ma'am?
I would like to say, like, all of us would agree probably that India is going to be the diabetes capital now, with increasing incidence of diabetes thanks to our lifestyles. So we are looking at an increasing incidence of gestational diabetes. So initially, when I was doing my post graduation, it was somewhere around 0.8 to 1.5%. Now it is at a range of somewhere around 20 to 25% is the incidence of diabetes. So gestational diabetes, one in every 4 pregnant mothers are having a possibility of developing gestational diabetes. So it is very important that we should look at screening for diabetes in the first antenatal visit itself, ma'am.
Yes. So, Prerna, would you like to add something there? And Uma ma'am? Uma Brinda ma'am?
Yes, madam.
Yes, ma'am. So in your area, what do you see more? GDM or diabetes or PIH?
We have recently we have an increased incidence of gestational diabetes, madam, and preeclampsia because of increased incidence. Pardon?
With the rising PCO incidence, on an average, we see around 2 to 3 cases of GDM in our antenatal clinics daily.
Yes. Routinely, we see 2 or 3 cases of GDM, and people are.
So the more you test,
we do OGC.
The problem is that people are not very versed on that universal screening program of 75 gram glucose and oral challenge test. The moment you give them the 75 gram glucose and the blood sugar comes out of 2 hours, 140 plus, they will say that you have already given me sugar, so it will definitely rise. This is what the rural population see. So I myself,
that is what everybody sees.
Yeah, so it's a lot of problem on this end. So even educated couples, they don't take it to the point that they are having altered glycemia because of the universal screening test that we are following. That's the issue.
They are screening.
Yes, Dr.
They are
Uma?
screening. They are willing for screening and they are taking OGCT. But the problem is, if you say that you have altered glycemic profile and you have to be started on insulin, that is the area where we find difficulty. They won't accept insulin injections. With,
but I think maternal nutrition is the first thing to be tried, right?
Yes,
Therefore, she is 144, 140, 150.
We find it difficult to, in the rural areas, to follow strict medical nutrition therapy. And if medical nutrition therapy fails and if we suggest insulin, the percentage of women accepting insulin is less. We have to educate them more and more.
I mean,
and regarding preeclampsia, we have about 5 to 10% or gestational hypertension with increased follow-up BP with increased BP recordings at the primary healthcare level. The incidence of preeclampsia has decreased now compared to previous, but still we have gestational hypertension more.
Ma'am, with
Dr. Pradnya
more and
Harshy
more
has joined us now. Welcome, Pradnya ma'am.
I'm sorry for joining so late. I'm so sorry.
No, that's all right. Means if you wish, you can join in the panel.
Yes.
No.
Jasa has yet to join.
I'm not so learned, ma'am.
Ma'am, I just
And we are
wanted
just
to add
discussing experiences. Yes, Monica.
with more and more people coming up with infertility, obesity is on rise. We have more PCOS patients who are conceiving at later ages. The incidence of GDM in IVF patients is much more than the general population, ma'am. This is what we
Agreed.
have seen in
Agreed.
our practice, ma'am.
Madam,
Yeah,
I
so
would like to comment
that
one
is
thing, madam.
multifactorial. Yes, sir. Yes,
Yes,
sir.
Madam,
Welcome.
because I just see OBG patients conceived with ART treatments only. So these subgroup of patients, which I see there is tremendous increase in GDM and preeclampsia. And I hope the same thing is with the normal people also. So we are seeing a general rise, especially in oocyte donors preeclampsia. And in normal patients, GDM is more.
Okay. But sir, we can do something about PIH, right? We can give
Yes,
them
ma'am.
aspirin
Yes.
and decrease the complications, because if you give aspirin, 70% complications are prevented.
Yeah, we put them on aspirin and low dose low molecular weight heparin from early itself, so to prevent all these things. And at 14 weeks also we do the scan and do the biochemical assessment for risk prediction of preeclampsia in these patients.
Thank you, sir. Sir, you are the expert here. Now, I would ask you, what do
Yeah.
you think should be the timing and frequency of ultrasound throughout pregnancy? Means minimum 2, 4, 6, 8. How many scans do you want in a singleton pregnancy?
Madam, with the current patient intentions also we have to take into consideration. Whenever they come with a urine pregnancy test positive after 6 weeks, I advise a scan at that time to confirm intrauterine gestational sac with a fetal heart. And then the next scan would be at NT. And again, T5 at 15 to 19 to 20 weeks, 24 to 26 weeks, a growth scan. And depending on requirement, we can do other scans around 15 days apart after that.
So, you do a growth scan at 24 to 26 weeks?
26 weeks, because I told you, madam, we deal mainly with patients with very high risk patients.
IVF patients.
Yes, so we do it at 24
Okay.
to 26 weeks.
Okay.
Yes.
So, thank you, sir. Thank you. So now are we doing anything about the mental health assessment? Are any of us actually even asking about the mental health of the patient? Because patients will come, they are taking medication for depression, some are taking medication for epilepsy. So,
Madam, can I comment on this?
How do
Can
we?
I comment
Yes,
on
sir.
this?
Yes, sir. Yes, sir.
Yeah, actually,
Yes,
we have daily yoga sessions for all the patients. Because depression and anxiety is a very common factor which we see in our group of patients. So they have it's a compulsory for them. We have an online class of yoga, which they have to attend daily. And we take into their consideration their anxiety, and there is a counselor for it who counsels on the mental aspects of their health also, which I think is an important point for the fetal development and fetal overall development also.
So, but you have very high risk patients. But
Yes,
in the
ma'am.
villages, I'm asking you, what do you think? Are we
Yeah,
actually even
madam,
thinking
the
of the
patients
mental
are high
health?
risk, but the patients are high risk, but they come from all places. It's not only the city people who I cater to. We cater to village people also. We just sit with them.
No, sir.
The
But
counselor
your patients are all IVF patients. I'm talking about the routine, the lady who's been married 2 years and she's pregnant and she
I
has
think
come.
they also
So,
should have such access to mental health care also during pregnancy.
yeah, so what do you think we need to ask to guess that this patient has some mental health issues?
Madam, if
So,
she's... Hello?
Ma'am, Pradnya ma'am is speaking. After that, I will speak, ma'am. Pradnya ma'am, please go ahead.
Ma'am, we work in a small setups and in small charitable hospitals where the workload is more. So what we generally ask is, the patient is telling that I'm not feeling well, I'm not able to sleep well, and she cries for no other reason, that's an early marker. This is what we are seeing right now. And the first complaint will be that I'm not able to sleep and I am anxious, and she'll complain of ghabrat all the time. Like the basic what the patient will complain of.
Yes, Monica?
Ma'am, generally what I do is I call the patient inside first. I don't take the relatives before I speak to the patient, because only after that the patient opens up to what exactly has happened at home. If the mother-in-law is at fault or if the husband is at fault, then we can give her the advice specifically to her, and then I call the relative inside and then also give the advice again. The needs in a rural place, ma'am, where we practice, most of the times people do not get rest at home. She is overburdened with multiparity. There are 2 to 3 kids to be taken care at home, and on top of it, she is breastfeeding one child. She has another child in her womb. So that also needs to be taken care of, because here she doesn't want the pregnancy, but everybody at home is insisting on that she should have one more issue just for either a male child or a female child to carry on the legacy at home. So these things also need to be counseled, and tender loving care is the most important thing that we can offer to these patients, because nobody is giving them at least a year to listen at home also.
Dr. Kiran, sir, would you like to add something here?
Yeah, mental health assessment during regular OPD is important one. While doing counseling, we get notice some abnormal points. Then we have to diagnose patient in stress, anxiety, sleep disorder, and we have to then manage it according to it. But it is more important this era, because lifestyle is changing. Job pattern of the patients is also changing. Some do night duties in IT, some do work from home. So mental health assessment is important for counseling in ANC visit.
Sujata ma'am, do you think we should have a mental health questionnaire sort of thing that you get your staff to administer, or it's okay? We can just assess by ourselves.
It would be better if we have a mental health assessment questionnaire. That's a good idea to put into practice. The basic identification as a doctor that we can do is their sleep pattern and any disturbances in the sleep, and any amount of physical activity they are doing to take for self-care. Basically, important thing is for self-care, are they doing any physical activity, yoga or any of the household works can be can be a part of it, but if they are able to dedicate some time for self-care, that is what we can look at. And another important thing I feel is, are they coming with a partner to the antenatal visits? So that's where we can assess the partner's support is there, and they're able to share things and receive the support.
So anybody has anything to add here?
Many of times we have a patient who comes every 3 to 4 days only with one complaint of pain in abdomen. You give her any amount of painkillers, the pain doesn't subside, she comes back to you. Then you have to actually ask her, what exactly is the problem? What you want me to tell your husband? Then she comes and tells us, okay, this is the problem. Please tell my mother-in-law this, or please tell my husband this, and I need to take rest.
Ma'am, we are doing a collaboration with Jaipago. It's a perinatal questionnaire they are given us, and we are giving it to our facilities. 20 facilities have registered for it. So we are doing that in Jabalpur.
Okay. Okay. So Dr. Uma ma'am, would you like to add something? And then I would come to Dr. Uma Shankar.
Yes, madam.
Yes, ma'am.
Yes. It's
Can't hear you, ma'am. There is something wrong with your.
Yes.
Hello.
Yes, madam.
Yes, ma'am.
Yes.
Yes. Now please go ahead.
No, madam. Like madam said, we should talk with the patient separately. She should be counseled separately without any attenders. She should be inquired first, and then what are the problems faced by her, or what are the difficulties faced by the patient should be asked, and then to talk with the attenders. And questionnaire, now we have come with the questionnaire, madam. We have a questionnaire in our setup.
Okay.
Both antenatal mothers and postnatal mothers. We have questionnaire. Yes.
Because what I find now is there is one class of patients, that is Dr. Monica's patients, who are, overworked at home. And there is another class who are obese, who have GDM, but who are very fussy and who don't move. When do you get up? I get up at 11. When do you have breakfast? I have breakfast at 2. So these are the people who need a reverse counseling also, I feel. And you need to have the whole family in as a support, because with this lifestyle, it's going to be very difficult to even bring up that child. So we need to think both ways about those women who are underprivileged and those who are overprivileged. I think we need to think of both issues. Now, this is the last most important question. That, do you think community-based antenatal care services, like the government has that Anganwadi workers, they have Asha workers, they have every pregnant woman being registered at the government facility, they are being followed up. Do you think this will improve maternal and fetal outcome?
Definitely, ma'am.
Yes, Dr. Monica.
Madam, we have seen a lot of.
Yes, sir.
Definitely, it's going to improve the maternal outcome, fetal outcome. Because what we have seen is most of the antenatal mothers are getting registered. They are getting good diet, and vaccinations also are being done regularly for the mothers and after the birth child also. So there is a lot of overall health improvement in the mothers who have registered with the community government healthcare for mothers, Anganwadis, and all these people.
So what percentage of your patients are registered? In my state, it is 94% who are registered.
Yeah, it falls on the same thing. 95 to 95% of my patients are registered with Anganwadi people. Even to say that my doctor who was pregnant and delivered recently, even she was registered, and even they gave her also, though she's a doctor, that you have to eat this diet, egg, and all these things. So that is the way the government is actually putting up efforts to give every pregnant woman diet after delivery also.
Ma'am, I have seen PHCs at the Pune Municipal Corporation also giving the influenza vaccine and the swine flu vaccines to the patients who have registered with them. So government is definitely doing a very good job. It's not that, and they have been given targets.
So the community program is a good program, ultimately.
Yes, ma'am.
More than that, I think it is the accessibility, the medicines, the investigation. Everybody is so thoroughly investigated. So, like,
because in our place, we have so much of sickling and thalassemia. But everyone is investigated. A sickling is done for everyone. If it is positive, anything, then they have their HPLC done. It's all done at the government center free of cost. So that sickle cell crisis deaths have gone down. Recently, I got a patient who came by herself that I am sickle cell trait. My husband is also sickle cell trait. So I want my baby tested whether it is SS or not. Luckily, the baby didn't turn out SS. But that awareness is coming up because the whole community is activated. So now we have different situations. If there is a woman who already has hypertension, so we want just 1 point answers. How are we going to adjust her antenatal monitoring schedule? In ultrasound, the 12-week scan would be?
Ma'am, the 12-week scan would be with dual marker and the preeclampsia screening. That is, the PGLF also needs to be done. Ecosprin
and the uterine artery PI.
Dopplers,
and the uterine artery PI.
Aspirin needs to be added as soon as her pregnancy test is positive. If she also had an episode of convulsion or preeclampsia, then high doses of calcium would also be recommended in her, ma'am. And she would need a regular follow-up in the antenatal OPD. At least after 14 to 15 weeks, urine dipsticks at every visit would be required, ma'am, with a strict BP monitoring.
What are the key ultrasound findings that we are going to adjust? We see the uterine artery PI.
Yes, ma'am.
We see all the Dopplers and We see the growth pattern, because what is happening is usually IUGR because of preeclampsia, right? Dr.
And we
Sujit, are
had a
you still
thesis.
there? Would you like to add a word? No.
Ma'am, our thesis
He's there,
topic
but he's
was
not there.
placentation and PIH. So we had more of lateral placentas presenting with PIH. So that also needs to be seen, ma'am.
Okay. Now, if she has hypertension, what are the dietary modifications to control her hypertension?
Ma'am, salt restricted diet, no achar papad, and try
High
less
protein diet.
Hydration has to be adequately maintained, ma'am, and her sodium intake needs to be restricted. We need to advise her that her diet should contain the adequate amount of salt which is required for taste, but anything which contains high sodium like pickles, then you have papads, then chutneys, which is very common in Maharashtrian thetsa, all these needs to be avoided, ma'am.
Dr. Sujata, would you like to add something here?
Yeah, regarding the diet, it could be a high protein diet and a well hydrated, balanced food, because she may be developing the PIH later on. So the fluid retention can be avoided if she cope ups with the loss with the protein intake. And regarding the antenatal monitoring schedule, it should be more frequent, once in every 2 weeks. And maybe if they have an access and they're able to monitor their blood pressure at home, it would be ideal. We teach them home blood pressure monitoring.
Okay. Now, she was supposing that patient was on telmisartan before she got pregnant. Now that she is pregnant, do you want to change her medicine or you want it to continue?
Yeah, we need to change the medication.
Antihypertensive we are not giving in pregnancy.
We
Or
need
what
to
are we
change
giving?
the medications to the safe ones. That is the labetalol, which is quite safe, and nowadays it's been found to be very easy accessible and with less complications. And if it is a cost factor, we can look at the L-methyl dopa. They have to
L-methyl dopa is not available. L-methyl dopa is not
either
available.
prescribe calcium channel blockers or beta blockers, beta sympathomimetics to them, and we would avoid ACE inhibitors for them
Exactly.
because
so
they are all
giving her,
having a risk
so
of
you can
IUGR.
shift her. So you can shift her on amlodipine, right?
Yes, ma'am.
You can shift her on amlodipine, but she has to be under supervision while the change is happening. Now, what lifestyle changes do you want her to do? Sir has already mentioned yoga.
She should have at least brisk, a part of at least 20 to 25 minutes of any form of brisk exercise in her routine, ma'am. And small frequent diet, low sodium, high protein, and adequate hydration. And stress reducing techniques like meditation.
She needs to exercise.
Yes.
She needs to exercise.
And any form of
high blood
stress.
pressure, so she is not to sleep.
Sleep.
Yeah. And what about, we remember in Williams, it's written that she requires 2 hours of rest in the afternoon. Do you still advise that?
Yes, madam, we advise rest in the afternoon. Yeah.
Adequate
sir, how is it even possible?
Sir, and what I tell the patient is listen to your body. When you feel like taking rest, you should take rest.
Post lunch nap, we advise, madam, usually in our place, in our practice.
Yes, we also
I think, it brings in a lot of relaxation to the patient, madam, especially post.
Sir, but your patient could be working in a bank. You don't expect her to rest in the afternoon. She cannot.
No,
all the people will give her so much more blood pressure.
No, madam, it is like she's a high-risk patient with a hypertensive problem. So she has to take that off, that's all. Yeah, because later on you should not be blamed.
Sir, you cannot have 9 months of off, not possible.
Not 9 months, madam, at least in the second trimester, if not in the first trimester.
Okay.
Yeah.
Okay.
We
So now,
normally
how are you
recommend
going to
15-minute walk after their every meal. that will
Yes.
cope up with the 45 minutes exercise that they can do.
Yes. So her delivery plans, what do you plan for her? If she's chronic hypertensive, she is not PIH, she is chronic hypertensive. What do you think? You want to deliver her normally, vaginally or abdominally, or it will depend on the ultrasound finding?
Ma'am, after she crosses around 37 weeks, it will depend upon the ultrasound findings and the clinical examination. The cervix has to be inducible. And if the cervix is inducible, then I would like to give her a shot of steroids at 36 and then deliver her after 37 weeks, ma'am.
So in chronic hypertension, you want to deliver it at 37.
37 or 38, ma'am.
You want to deliver at 37 to 38.
It is
Now,
38.
post. Yes, ma'am. Pradnya, ma'am.
Ma'am, 37 to 38. That's it.
And without any.
So you're not crossing 38.
Yes, ma'am.
Without the
In
superimposed.
postpartum, is there anything?
With
postpartum, is there anything you are looking at?
Ma'am, postpartum cardiomyopathies are more common. Fluid overload immediately post-delivery because we put in a lot of fluid, so that needs to be monitored in these patients. Fluid restriction post-delivery. If required, then we can add diuretics also post-delivery because otherwise we don't give diuretics to antenatal patients.
Okay, so basically you're not going to discharge her in 24 hours. You're going to keep her under observation for at least 3 to 4 days.
72 hours if she is delivered normally, ma'am, and at least on the 5th day, 96 hours, that is if she has undergone a cesarean section, ma'am.
Okay. So anybody wants to add anything to a woman with hypertension? Or I go to the next case because we are going to be really fast now.
Should we be doing a echo, 2D echo in the
That
antenatal
is compulsory if she is
Without
chronic
any
hypertension, you have to do echo.
Yeah, so one of
You
the
have to
first
do echo.
antenatal visits probably we should be looking at.
This is GDM. So we've done the DIPSI test and we've diagnosed GDM. But in which trimester would you call it GDM and when would you call it pre-existing diabetes?
Any high sugar level diagnosed during delivery, diagnosed during antenatal period is gestational diabetes only, madam. But if one
No,
of the
ma'am.
values,
If she has the first visit, she's come to you at the first visit. She is
according
6
to
weeks
the
pregnant.
According to definition, any hyperglycemia diagnosed during pregnancy is gestational diabetes. But if any of the value is more than 200 and the early trimester, if she is diabetic when for the first visit itself, then she is called pre-diabetic.
Anybody wants to differ? Sujata, ma'am?
Yeah, we when we do a first testing in the first trimester itself and you find that she's got a high sugar levels, it could be a pre-existing diabetes only. So we have to diagnose this at the first trimester, but we give it as gestational diabetes when it is appearing for the first time after 24 weeks.
24 weeks.
So that is 24 weeks.
Ma'am, if it is in the first trimester and if I have a higher sugar level, I would also advise her an HbA1c to see the record of the last 3 months.
Exactly.
And accordingly, I would also advise her if her HbA1c is very, very high, she's at a higher risk of neurotube defects as well. So in consideration, an ultrasound and if required an MTP also if it is uncontrolled, ma'am.
Okay, so how are you going to modify her antenatal visits now? She has high blood sugar levels. So how are you going to modify her antenatal visits? What are you afraid of?
Sudden hypoglycemia as well as sudden hyperglycemia, which could lead to sudden intrauterine fetal death also, ma'am. So we need a strict sugar control as well.
Polyhydramnios and preterm labor?
Preterm labor. Yes, ma'am. She needs to have a very strict sugar control to avoid macrosomia also, ma'am.
And can such a patient have IUGR?
Yes, ma'am.
Yes. So What fetal growth monitoring we've already discussed. Now her diet. Like you are from Maharashtra, they will happily eat jowar, right? But if you go to the south, their staple now is rice. Previously, they used to have bajra, they also used to have ragi. But now the elite are not taking so much of ragi and all.
Calorie restriction is what we advise, ma'am. Whatever form of carbohydrate according to the area, but calorie restriction is a must. They have to include lots of proteins and lots of vegetables also. Lots of fruits, but those fruits which have a higher glycemic index needs to be avoided, ma'am.
Sujata, ma'am?
Yeah, as you said, ma'am, in South India, it's more of rice eating. And so simple things like, as Dr. Monica was telling, high protein diet. So instead of eating idli and dosa, we ask them to have the pesrattu, that is, which is made of green gram. So the amount of rice content in that is less, and it's made of sprouts.
What did you say? What name did you take, ma'am?
Pesrattu.
It's a pesrattu. It's a moong dal dosa, ma'am.
Moong dal dosa.
Okay.
And if they are non-vegetarians, we ask them to add the omelette even in the breakfast instead of having the dosa and idli. So these are the things, like it's a high protein diet is what we are going to encourage them. Basically, it is the breakfast which is the main culprit of where the carbohydrates are consumed more. So encouraging them to have lots of sprouts and fruits in the breakfast can cut down on the sugars.
Okay, now if she has GDM, we put her on insulin. Okay, and it has to be an atrapid only, right? So how frequently would you advise that? Twice, 3 times, 4 times?
3 times, ma'am, before each meal.
Okay. And would you like to involve a physician, or you want to do it yourself?
Ma'am, a physician is definitely more helpful because then they monitor their sugars every 15 days, and we can ask the patient to monitor their sugar with a glucometer at home. They give them a proper chart saying which day they need to do a before test and which day they need to do a after test. With looking at the charts, we can then modify their insulin requirements accordingly.
So now the well-being, we know how to assess. Now we come to, when do you want to deliver this patient? She has GDM. How many weeks do you want to carry her?
Ideally at 38 weeks, because they are more prone to their lung maturity is less as compared to those patients who have eclampsia.
Yes.
37
so 38 weeks is what we
37 complete,
recommend.
or at least at 38.
38 is the recommendation for GDM, provided her Dopplers and everything help her carry that long. Yeah. So in postpartum, what are you going to follow her up with?
Ma'am, I generally do a fasting and
baby for
post-lunch.
hypoglycemia, the baby for hypoglycemia and hypocalcemia, and the lady for.
We need to monitor her sugar. Ma'am, her sugar levels will suddenly drop because the placenta, which is the main cause, would be out. So her sugar requirements, the insulin requirement will drop in the postpartum period. So what we generally do is we do sugars every 6 hourly on that first day, and I do fasting and post-lunch on the third day, and then readjust the dose accordingly. And after 1 week, she can follow up with her diabetologist, ma'am.
Yeah, so if she did not have prior diabetes, then 30% are going to end up with diabetes at the end of 3 months. So you have to call them back at 3 months, whether it is a hypertension or a diabetic patient. So at 3 months, we are calling them up. Now, this is a patient who has a history of preterm birth. What are you going to focus on in this patient?
They would
in
need
ultrasound, what is?
They would need more frequent antenatal visits and more frequent ultrasound assessments. Serial shortening of the cervix is what we would be looking at to rule out any cervical incompetence as a cause of preterm birth. And the second I feel the major cause for preterm birth is infections. So it is ideal that we encourage them to get their urine cultures, and if at all positive, get a high vaginal swab cultures done once in every 2 weeks, if we are looking at ruling out infections as a possible cause.
And for what I would like to add in history taking is I want to understand whether it was because of cervical incompetence, whether the onset of labor was painless or whether it was painful with leaking or vaginal infection. That would give me a more insight to whether to monitor and post her for a cervical os tightening in the next pregnancy at an early age, say around 14 to 16 weeks. So she might need an os tightening if it was due to cervical incompetence, but only if the source was infection, then os tightening may not be required in this pregnancy if we screen her infections properly, ma'am. And there is oral hygiene.
Prophylactically giving her progesterone? Are you going to give her prophylactic progesterone?
Yes, ma'am. Vaginal progesterones, ma'am.
Okay. These days, dydrogesterone is so much the urge. So do you
The
think
cost factor, ma'am. The cost factor is important, ma'am, in our setups.
Okay. So you would do os tightening if there is incompetent os or it is shortening. You would do, you could give progesterone if the patient can take it. Would you want to give her, you see her cervix length is maintained, but because she has history of preterm labor, do you want to give her corticosteroids at 28 to 34 weeks or not? There is no finding. Would you still want to give her steroids?
Yeah, we can.
I will give, ma'am. There is no harm in giving it, ma'am.
32, 34
Sujata,
weeks.
34 weeks.
32, 34 weeks, not at 28.
Because then even if we give it at 28 weeks, it will be required to be repeated at 32 to 34 weeks.
So you've done a vaginal os tightening. The patient has now carried past 34 weeks. So do you want to hasten her delivery? When do you want to cut her stitches?
After 36 weeks, ma'am.
At the onset of labor.
At 36 weeks, ma'am.
Okay. And now she has reached 38 weeks and she's still not delivering. Nothing is happening. What will you do?
Remove the stitch and go for induction of labor at 40 weeks, 39, 40.
40 weeks.
And postpartum, what are you going to care for her? If the baby is preterm or if the baby is full term?
With the preterm baby, the baby needs to be followed up properly, ma'am. Because there would be higher incidences of retinopathy of prematurity. There would be developmental delays, which would be needed to be followed up. And neurodevelopmental assessment at every visit should be a must. And weight gain of the baby needs to be monitored, ma'am.
Okay. Now today we are doing antenatal care. So I'm leaving these questions aside. I'm just asking you one thing. That if it is a monochorionic twin, when do you want to call her for monitoring? If it is dichorionic, when do you want to call her for monitoring?
Ma'am, monochorionic at least every 10 to 15 days because there is a higher risk of twin-to-twin transfusion, cord entanglement. So I would like to call her more frequently, as I call the DCDA twins would be at least every 15 to 20 days, ma'am, depending upon where she stays here.
See, actually the guideline is that you need ultrasound every 2 weeks for a monochorionic twin, and you need it every 4 weeks for a dichorionic. Okay, if it's dichorionic, it's every 4 weeks. If it is monochorionic, it is every 2 weeks. And that is how you have to follow up this patient. And then delivery considerations will depend on the obstetric things. So are we going to do a circlage on having a twin pregnancy? Do you give a circlage to every twin pregnancy?
It will depend on her cervical length at 16 to 20 weeks, ma'am.
No, so means you are not giving it to every twin pregnancy.
No prophylactic os tightening, ma'am.
Exactly. So what are the postpartum considerations that are unique to multiple births?
First, we
What
need
is
to
most
address
important?
breastfeeding. We need to address lactation issues, ma'am. First.
Exactly. Exactly. How she's going to feed 2 kids. Right.
And she
So
has to have
that
an
is
adequate
the
home help. That is where we start priming around 32 to 33 weeks, that you always think about 2 people who will be there with you to take care of your kids along with you once you deliver, because those 2 need to be identified, and they also need to be properly counseled regarding the advantages of breastfeeding.
agreed. So if there is IUGR, then we depend so much more on the ultrasound. We are depending on the ultrasound. We see that the growth. Now, before I say fetal growth restriction, when do you do the earliest ultrasound that will tell you that there is growth retardation?
Ma'am, around 27 to 28 weeks.
See, 28 weeks is where you want your IUGR baby to reach. A pregnancy less than 32 weeks with growth restriction is early IUGR. More than 32 is late IUGR. So basically, anytime where you find that the fundosymphysial length is not growing as it should is when you advise an ultrasound. So this is the point that we take away, that you need to monitor that, properly monitor it and document it, because that is where your routine ultrasound is not happening, right? You've done it at 20 weeks and then you've left it because the guideline says go for 36 weeks now.
36 weeks.
So unless you are able to examine your patient and find out that something is wrong, you're going to be in a soup. So it is the clinical examination that will tell you to advise an ultrasound and then corroborate your diagnosis and then treat as per early or late IUGR, whatever. Now, if she is obese, has a BMI of 40, what are your guidelines to this woman?
A severe calorie restricted diet is a must. She has to cut down on her sugar intake and refined bakery items also, ma'am, because then that will lead to excessive weight gain even in pregnancy. She has to improve her vegetable and fiber content.
How many kilograms are you going to advise her? In pregnancy, you can gain up to this much.
Not more than 8 to 9 kgs, ma'am, in a patient who has such a high BMI.
No weight gain, ma'am.
5 kg. 5 kg. It's only 5 kg that is allowed as per guidelines. If she has a BMI above 30, you advise her only 5 kg of weight gain. Okay. And what are the complications that are specific to obesity? If the mother is very obese, what complications can the baby have? The pregnancy have?
The first thing, ma'am, she is more predisposed to preeclampsia as well as gestational diabetes mellitus. Secondly, her ultrasound may not be very much fruitful because of the obesity. The window, scan window is very, very limited for us, and we might not be able to pick up a lot of anomalies in these patients. So in case if required for neural assessment, we could also go in for a TVS even at 13 to 14 weeks if possible, so as to assess them. Dietary counseling is very, very important, ma'am, in these patients, as well as if we don't advise her, then she might land up with more and more complications of obesity like sleep apnea. Because with the baby and her weight, she will, I have seen patients who also needed a BiPAP at night, ma'am.
So she can have sleep apnea, she can have preterm birth, she can have abnormal fetuses because of the weight. Anomalies are more common. There can be preterm labor, and there can be intrauterine death, oligohydramnios. These are all complications. So now this is a woman who has no complication. How is she going to be monitored? What is the frequency that you want to monitor her with?
Once in every month.
Yes.
3 to 4 weeks, yes, ma'am.
And okay, what vaccination do you give to your pregnant women?
Ma'am, tetanus toxoid, 2 doses, but now diphtheria and tetanus is available. DT is
TD
available.
and Tdap.
Tdap, both are available, and DT is given free of cost from the government, ma'am. So we generally give that only.
Okay.
If the
And do
patient
you
is
give
willing to
influenza
pay, then
vaccine?
Tdap is. Yes, ma'am.
Influenza vaccine?
And people
Do you
here
give
are not very.
influenza vaccine?
We advise, ma'am, but people here are not very keen on spending more money. Whatever is free, they will take, ma'am.
Sujata, ma'am?
16 weeks we give the flu shot, and 26 weeks we give the Tdap.
Okay. Okay. So basically, there are only 3 vaccines. One is your TD, Tdap, and influenza that you're giving routinely in pregnancy. Do any of you advise HPV vaccine after baby is born?
Yes.
Or cervical cancer screening?
Postpartum, yes.
Do you
Postpartum,
advise
yes, ma'am.
physical activity? Do you advise physical activity to the patient? She is a
Yes.
normal patient. She has no complication. But do you advise her physical activity, dietary considerations?
Yes, ma'am.
And advice about lactating and taking care of the child if she's a preemie?
And before
Now,
she
this
goes,
is a woman who's...
yes, ma'am.
Yes.
Before she goes home, the importance of ambulation, that there is an increased risk of venous thrombosis in the postpartum period, that I explain to every patient. I explain hydration to every patient, because here most of them don't give water post delivery, ma'am, thinking that the baby is going to suffer. Here the water restriction is at least only 1 glass of water is given to the lady who is delivered, ma'am. She lands up with UTI, she comes with fever, dehydration, she comes with venous thrombosis, sagittal venous thrombosis. Also, I've seen convulsions because of that, ma'am.
So that is one thing. So we need to give her dietary advice and ambulatory advice and advice on taking
Hydration
care
and
of the
feeding.
child. Yeah. Now, this is a patient who's very thin. So how much weight do you want her to gain? Her BMI is 16. So how much weight do you want her to gain?
She can already gain around 12 kgs, 11 to 12 kgs could.
Actually, the guideline says that you count that 11 kg from her normal weight. So a BMI of 20 and then you start counting 12 kg. Before that, it is just makeup. Okay. So because if she has very low BMI, then there is FGR, preterm birth. She can have nutritional deficiencies, higher placental abruption, higher miscarriage. Then she is low immunity, obviously. So she gets infections, transmits those infections to the baby. All these problems can occur. So we need to see that our patients have a correct BMI and have a correct, or they are able to restrict or increase their diet as per the needs of their pregnancy. And we teach them how to look after themselves. Do you have any experience of those creams that they give, to prevent stretch marks, which are all the craze? Have you found them effective?
No, ma'am.
Anybody who's found those creams effective? No.
Ma'am,
so I tell my patients. Yes.
Simple coconut oil or almond oil after 12 weeks of pregnancy, ma'am.
Ma'am, even bio oil is doing well.
Yes,
like olive oil, even plain coconut. And if you are affording, then those creams do help.
Okay. My experience is if you have a very dry skin, you're going to get stretch marks. If you have an oily skin, you don't get stretch marks. And whatever symptoms are there, we can just manage them. So now we come to the take-home messages. And I would request each of my panelists, thank you so much for being here. And I would request you to give take-home messages before we end the session.
Madam, thank you so much for a very extensive coverage of all the antenatal monitoring. So one thing what we have to emphasize here is the importance of regular antenatal visits and early identification of the complications.
Thank you.
Thank you, ma'am.
Thank you, Dr.
Thank you, madam, for involving this
Pradnya, ma'am.
wonderful workshop, panel discussion, madam, CME. Thank you, madam.
Thank you, sir. Sir, take home message from you for antenatal monitoring.
So we have to first take into consideration of the patient condition and follow our guidelines and make sure they have a safe delivery. And each one with their own set of patients, develop your own antenatal guidelines, follow up, and then do the screening and all the things, madam.
Thank you. Thank you, sir. Pradnya, ma'am.
Ma'am, I think
something
what
to say.
Telling is very true, because what works in our setup, we should do that. And regular counseling, especially the Garbh Sanskar is doing wonders for my patients. So I'm advocating that a lot. That's really helping.
Okay. Pradnya, Monica? Dr.
Ma'am,
Monica?
inverting the antenatal pyramid is what we should all work towards, because that is going to decrease the number of complications for at least after 28 weeks. So we need to pick up early so that we can start treatment early. That is, most of us are still reluctant of doing an NT and a dual marker, ma'am. That is what we need to highlight.
Be incorporated, 100%. And it should be standardized.
Thalassemia, sugar and thyroid needs to be screened very, very early in pregnancy, ma'am.
Yes, ma'am.
All those that can be prevented has to be prevented. There is no escape, ma'am.
That is true for all of obstetrics and gynae. Prevent the preventable. Prevent the preventable. Geeta ma'am, would you like to say something? Parneet ma'am, would you like to say something? Then I'll come to you, Sujit. You'll also have to give one take-home message, though what we are talking is mostly what you've taught us. They aren't answering, so it's up to you.
Yeah, I will like to have one comment about the late FGR entity is most neglected entity. I think about I observe all the discussion, because nobody is going to stress on that. The importance of 36-week sonography with Doppler is very, very crucial. You cannot diagnose late FGR unless and until you do 36-week sonography with Doppler. I already told 40% of intrauterine fetal deaths are because of late FGR, which were labeled unexplained in previous days. So you have to stress upon this sonography in your routine practice.
Thank you. So prevent the preventable and be alert, tailor your practice, but tailor it to the guidelines. So don't give up on the first trimester NT scan, don't give up on the MTAS, and don't give up on the growth scan. Do those 3 scans, but don't give up on your clinical monitoring as well. You have to get up and examine your patient. Please do that. So I think Kamal Buckshee ma'am is still there. Ma'am, if you are there, if you would like to say a word, we are here for you. Otherwise, thank you so much, our guest of honor, chief guest.
Can I add, ma'am, one more sentence, please?
Go ahead. Go ahead.
Ma'am, oral hygiene is also very, very important to prevent preterm labors.
Yes.
Because we have seen patients who have undergone root extractions. Because those who have undergone a root extraction have landed up in preterm labors also. And red degeneration of fibroid also needs to be monitored if she has an existing fibroid, because that also could be a cause of preterm labor.
Yes. So thank you, Kamal Buckshee ma'am. Thank you, Dr. Geeta, Dr. Parneet, Dr. Pradnya, Dr. Sujata, Monica, Dr. Sujit, and all my chairpersons, panelists, experts, guests, convener, and all the viewers. Thank you for being here with us. See you again next week, Wednesday, same time, talking on a gynec examination. What does a gynec examination mean? So thank you. See you again.
Thank you.
Namaskar, Shubh Ratri.
Thank you, ma'am,
Good
for
night.
involving us, and wishing you all the very best, ma'am, and wishing you the best, Sujit sir, too.
Thank you. Thank you.
Thank you, ma'am.